Good morning, good afternoon, and good evening. My name is Firman Witular from the ANU Indonesia project, and it's my pleasure to welcome you to the second day of the ANU Indonesia Update 2021. We would like to first acknowledge and celebrate the first Australians on whose traditional lands and airways we meet, and pay our respect to the elders, past and present. Today, I'm very honored to introduce the Australian ambassador to Indonesia, Her Excellency Penny Williams, who will make the welcoming remarks. Ambassador Williams is a senior career officer with the Department of Foreign Affairs and Trade and was recently Deputy Secretary in the department. She has previously served overseas as High Commissioner to Malaysia and was Australia's first ambassador for women and girls. She is also Australia's first female ambassador to Indonesia. Ambassador Williams holds a Bachelor of Asian Studies focused on Indonesia and a Master's of Applied Anthropology and Participatory Development. And as many of you know, she is fluent in Bahasa Indonesia. The screen is yours, Ambassador Williams.
Thank you very much and good morning, everybody. Thank you, Firman. One thing that's missing from my CV, can I say, which is perhaps the greatest thing to recall, is that I was once a photocopying assistant while I was studying Indonesian at the ANU, the Indonesia project. So I've got a long association with the Indonesia project. I studied Indonesian at ANU and I've attended many Indonesia updates throughout my career. So it really is such a great pleasure to be with you on this second day of the Indonesia update as Australia's ambassador to Indonesia. In his remarks yesterday, the Minister for International Development and the Pacific touched on just how closely Indonesia and Australia have worked to address this pandemic together. It's, of course, by now abundantly clear that the COVID pandemic presents the greatest global challenge of our generation. This challenge has actually highlighted the strength between our two countries, a partnership which has grown stronger in recent times, not despite the challenge of the pandemic, but because of it. As the Minister for Foreign Affairs, Senator Payne, said in her speech to the foreign policy community of Indonesia here in Jakarta just last week, our partnership affords us the strongest possible base from which we can continue to grow and support the health, prosperity, security, and stability of our Indo-Pacific region. We all know, and you've heard yesterday and will hear over the course of today, just how devastating the COVID pandemic, and particularly the recent surge of cases, has been for communities here in Indonesia and for the Indonesian health system more broadly. Australia's work to respond to this crisis in partnership with Indonesia has been targeted and it's been timely. The latest batch of 500,000 doses of life-saving vaccines supplied by Australia arrived in Jakarta just last Wednesday. This means, through our partnership, that Australia has now delivered 1 million AstraZeneca doses to Indonesia as part of the commitment to share 2.5 million vaccine doses in 2021, announced by the two foreign ministers on the 7th of July. This support, in addition to Australian support of $107 million for vaccine procurement, will see a total of approximately 13 million doses delivered to Indonesia by Australia this year. And this is on top of the broader support that we've been delivering, as Senator Zelzer outlined yesterday. This includes our package of 1,000 ventilators, 700 oxygen concentrators, 170 oxygen cylinders, and 40,000 rapid antigen tests. But one thing I wanted to highlight today is that our assistance also includes a new package of $13 million in recognition of the significant health, social and economic impacts of the COVID pandemic in Indonesia. This package of assistance, announced by Foreign Minister Payne in Jakarta last week, will support local health responses, including the procurement of essential medical supplies, the delivery of vaccinations and contact tracing. But perhaps even more importantly, it will address the impact of the pandemic on local communities through support with basic needs and food security, safe spaces for quarantine, psychological counselling, and better communication to counteract disinformation. This assistance will be delivered through long-standing established partnerships with Indonesian, Australian and international NGOs and UN agencies, community organisations and provincial governments, allowing support to get where it is most needed to get there as quickly as possible. Our partnership with Indonesia, which enables us to deliver this broad range of targeted, timely and effective support, really is a testament to the way Indonesia and Australia work together. And it's also a testament to our ability to collaborate to achieve results, be it at leaders level between President Widodo and Prime Minister Morrison, or between staff in the embassy working here with their counterparts in the Indonesian government. It's also important to say that Australia and Indonesia alike recognise that we can't recover alone from this pandemic, that our individual recoveries rely directly upon the broader recovery in the Indo-Pacific region we share. Australia's commitment to supporting regional and global solutions is also the driver behind our package of $100 million in assistance to the Quad Vaccine Partnership and of $130 million to the COVAX Advanced Market Commitment. I want to particularly acknowledge the very strong leadership role Indonesia has taken in our Indo-Pacific region to support stability through this crisis. This leadership, including through Indonesia's role as a driver of the ASEAN outlook on the Indo-Pacific, has never been more important. We also recognise that a full recovery from the health pandemic will need to include consideration of economic recovery. Indonesia has been hit hard by the pandemic, with GDP contracting by over 2% in 2020, and that was before the devastating second wave. Nevertheless, Indonesia's natural endowments and its demonstrated resilience still keep it on track to be the fourth largest economy in the world by 2050. But to recover fully, Australia and Indonesia will need to work even more closely together to strengthen the economic partnership between our two countries, underpinned by the Indonesia-Australia Comprehensive Economic Partnership, or IECEPA. Working to build and strengthen the relationship between Australian and Indonesian business is a key focus of the Australian and Indonesian governments, and it's certainly a task that the Prime Minister has set me in taking up my role here as Ambassador to Indonesia. But so too, and this is important to me as somebody who spent time as a young person in Indonesia, is working to ensure that we maintain close connections between our people as the pandemic subsides and borders reopen. Ladies and gentlemen, this pandemic has posed immense challenges for all of us. Today, though, I want to acknowledge both the strength of our response to these challenges, including through the effort we are all taking by being here today to continue the mutual understanding between Australia and Indonesia. And I really want to particularly acknowledge our conference conveners this year, Dr. Firman Witular from the ANU and Dr. Aryan Utomo from the University of Melbourne. Thank you very much once again for inviting me to join you today. Terima kasih.
Thank you very much, Ambassador Williams, and welcome everybody to day 2 of the 2021 Indonesia Update in Sickness and in Health, Diagnosing Indonesia. My name is Kirsten Bishop, Minister Councillor, Governance and Human Development with the Department of Foreign Affairs and Trade at the Australian Embassy in Jakarta. It's my pleasure to chair panel 2 today with the theme of Navigating Health Transition in Indonesia, Challenges and Lessons Learned. Firstly, noting that this virtual event is being hosted by the Australian National University in Canberra and that many of you are joining this conference from around Australia, I would also like to acknowledge and celebrate the first Australians on whose traditional lands and airways we are virtually meeting and pay our respect to the elders past and present. It is my great honour to introduce our 3 very distinguished panellists for this session. Firstly, Bapak I Nyoman Sutarsa, who will present today on navigating access to healthcare in Indonesia, a socio-structural analysis. Pak Sutarsa is a lecturer at the Rural Clinical School, Medical School, the Australian National University, and the Department of Public Health and Preventative Medicine, Universitas Udayana, Indonesia. He's a public health physician with extensive work experience across academia, government and non-government institutions. He graduated as a medical doctor from Universitas Udayana, received a Master of Public Health from La Trobe University and a PhD from the ANU. Pak Sutarsa's core experience is in public health and health systems, particularly the social and political dimensions of health system practices. Secondly, Professor Adi Utarini, who will present today on eliminating dengue in Yogyakarta, lessons learned from public health innovations. Professor Utarini is a graduate of the Faculty of Medicine at Universitas Gadjah Mada and has completed a Master of Public Health and Master of Maternal and Child Health at University College London and has a Doctor of Philosophy from Umeå University, Sweden. And since 2011 has been the Professor in Public Health at the Department of Health Policy and Management, Faculty of Medicine, Universitas Gadjah Mada. Professor Utarini's research focuses on the management of disease control, particularly dengue, tuberculosis and malaria, and quality of care. Since 2013, Professor Utarini has been leading the World Mosquito Program in Yogyakarta, where she provides overall leadership of the research and stakeholder management. In recognition of this work, Professor Utarini has received the Habibi Research Award in 2019, was acknowledged in the Nature's 10 list of the 10 people who helped shape science in 2020, was included in Forbes Indonesia's 2021 list of 10 inspiring women, and as recently as yesterday, has been listed in Time magazine's 100 most influential people of 2021. Professor Utarini is currently leading the national consultant team for developing Indonesia's national strategy for dengue control. And thirdly, I'd like to introduce Ibu Dia Satyani Saminasi, who will present on transformed primary healthcare in COVID-19 response, the case of the Puspa intervention in West Java, Indonesia. Ibu Dia is an Indonesian psychologist and public health practitioner with over 20 years of professional experience. Since 2018, she has served as Senior Advisor on Gender and Youth to the World Health Organization Director General at the WHO headquarters in Geneva. From 2014 to 18, Ibu Dia also served as a Special Advisor to the Indonesian Minister of Health in the area of partnership and sustainable development goals, where she chaired the National Health SDGs Secretariat and was a member of the Steering Committee for Indonesia's Global Health Security Team. And prior to that, in 2010, Ibu Dia joined the Office of the President in Indonesia as a Special Envoy for the Millennium Development Goals, where she designed and implemented behavioural science methods for reshaping public policy. Ladies and gentlemen, in terms of the structure of our panel session today, each of our panellists will be speaking for 20 minutes, after which we will have approximately 30 minutes for question and answer. Audience members, whether joining us by Zoom or on YouTube, are welcome to ask questions at that time. On Zoom, this can be done using the Q&A box or by clicking the raised hand icon. And on YouTube, this can be done by writing your questions in the comment box. So without further ado, I would like to hand over to our first panelist for today, Bapak I Nyoman Sutarsa. Pak Sutarsa, the screen is yours.
Thank you very much, Kirsten. So let me try to share my screen. I hope it works. Can you see the screen already, Kirsten? Not yet.
Yes.
Yep. Is that the presenter view or the presentation slide?
It looks like presenter view.
Right. Okay. Can you see the notes or just the full screen, Kirsten?
Green.
Okay, good. Good afternoon, everyone, and also selamat pagi for participants from Indonesia. And thank you for the lovely introduction, Kirsten. And I also would like to thank the Indonesian Update for the invitation for this particular panel. So my talk this afternoon is basically will concentrate on navigating access to healthcare in Indonesia. And I'm hoping to shed light on different ways of framing and talking about the issues, particularly for the marginalized population in Indonesia. So just to give you the overview of the session, so this session will explore the interconnected systemic risk of access inequities, which are more vulnerable, which are more visible during the COVID-19 pandemic. I will also use two case studies from Bali province and to discuss the intersection of various systemic risks, including system of oppression, influencing people access to health services and health outcomes. And towards the end of my presentation, I'll argue the fundamental of the intersectionality approach to explain the structural causes of health inequities and the imperative of intersectional policy analysis in formulating a solution to promote social justice and health equity in Indonesia. And in the next 20 minutes also, I would like to introduce these four main topics. So I will start my presentation with contesting health risk during the COVID-19 pandemic, and then followed with two case studies from Bali province in West Bali and Denpasar city in the central of Bali province. And I will follow that with the explanation about structural origin of access inequities, and we'll conclude with addressing health inequities from the intersectional perspective. Yesterday, we listened quite a lot about the current situation of the COVID-19 pandemic in Indonesia and what does it mean for the health system as well as for the inequities in Indonesia. So today, I would like to highlight again that since March 2020 until now, more than 139 Indonesians have died because of COVID-19. And this number seems to be still underreported because there are a lot of deaths that not be able to record in the Indonesian data set. Various policies have been implemented by the Indonesian government to minimize health and public health impacts from the pandemics. However, as we listened yesterday from several speakers, the impacts of the pandemic or the pandemic poses multidimensional risk. So it's not only public health or health risk, but we're also dealing with economic, social, and even political risk. And unfortunately, these risks are not equitably distributed across the segment of Indonesian society. As illustrated here by the story of Rubiam, an informal worker selling instant coffee around the prison of Jakarta, social movement restriction along with self-isolation policies enacted by the government of Indonesia have exacerbated further her social suffering. Unable to sell coffee means no income for Rubiam. Together with more than 70 million informal and daily workers in Indonesia, Rubiam is disproportionately affected by the pandemic and its control measures. This example tells a story about the intersection between health, rubium contesting health risks within the Indonesian society, and how health risks actually intersect with social and economic risks that operating at the individual as well as community levels. And our moral obligation has to be to protect this vulnerable population from further social suffering during and perhaps after the pandemic. So the emergence of the COVID-19 pandemic has amplified the existing access and health inequities across the globe, including Indonesia. Social and structural factors, including geographical location, social economic location, employment structures, lack of social protection, maldistribution of wealth, as well as maldistribution of health resources across Indonesia, housing and living arrangement play a major contribution in explaining the inequitable effects of pandemic among the marginalized population. They find it challenging to adhere to public health direction, including social distancing and self-isolation because of their living arrangement and employment structure. Or they find it difficult to pay for regular testing, for example, because of their unsustainable income source, or to practice good hand hygiene without adequate access to clean water and sanitation. These populations also likely to continue working during the peak of the pandemic. They also tend to bear higher burden of comorbidities, including COPD, diabetes, or other chronic conditions, leading to higher mortality rates. In many situations, working from home, unfortunately, is not a feasible option for this population, given their working environment, their employment structure lead to an increased exposure to the virus and the worsened overall prognosis of the infection. So what this narrative tells us, so the pandemic reveals that access and health inequities are indeed not a random event, but it is a product of interconnected system of oppression and privilege that operate simultaneously at the individual levels as well as at the community level. So therefore, COVID-19 actually presents itself as an opportunity for Indonesia as a collective identity for transformation to promote social justice and rights to health. It is imperative to fully comprehend the root causes of access and health inequities in Indonesia if we are to take action to eliminate them. The COVID-19 pandemic has shown the significance of consequences faced by those disadvantaged community and highlighted the predicament they face in the intersection of pandemic and the poverty. To put the inequitable access to healthcare into context, I would like to introduce you to Asana and Fifi, two transgender individuals from West Bali and Denpasar City. Their lived experiences and their stories from the margin expose the interrelation between this systemic risk. Let me introduce you to Asana. Asana was a 26 years old a transgender person from a small district in Jembrana district, one of non-priority district for HIV prevention in Bali province because a low prevalence of HIV. A transgender person occupies an uneasy position in the Balinese society, especially in a small village where Asana spent most of her life. Balinese society follow patriarchal structure where men gain more privileges than women. For example, the line of family and inheritance. Coming from this perspective, her father and many people around her had blamed her for her choice. She was socially punished because she did not conform to societal expectation. She was perceived as deviant and socially sick for transferring her gender role from men to women. And for some people, this act is simply assumed as a sin. In October 2016, Asana was admitted to Jembrana District Hospital with shortness of breath, and she was diagnosed with pulmonary tuberculosis. She was referred to a voluntary counseling and testing services, and her result came back positive. This information spread quickly. Every staff member at the Health Office and AIDS Control Commission learned about her HIV status. One staff member even proclaiming disease a disaster, insisted on obtaining sexual contact information directly from Asana. From that day forward, she was no longer entitled to privacy. She became a subject of public health, biomedical, as well as moral surveillance. She commenced tuberculosis treatment a few weeks after her first diagnosis. However, her immune system was too weak to initiate HIV treatment, 18 months after her first diagnosis of tuberculosis and HIV co-infection, unable to take treatment for HIV, she died. Despite the availability of HIV testing in 14 facilities in Jembrana district and the availability of the life-saving medication at the district hospital, the microanalysis of asanas reveals the catastrophic effect of inequity of access to essential HIV services in Bali province. The access inequity experienced by asana is not a random event, but rather a direct result of multiple oppression. To contrast the lived experience of asana, let me introduce you to Fifi, my second case study. Fifi is a 32 years old male to female transgender working as a project officer at a local NGO that provides HIV-related outreach and peer support group for transgender people in Denpasar City and Badung District. Unfortunately, her NGO does not cover Jembrana District, where asana resided and died. Fifi has the privilege to be in regular contact with extensive social support and available health services, including free HIV testing, free STI services, HIV treatment, and treatment for opportunistic infection. Fifi caught the virus 7 years ago, and now she is on regular HIV treatment. Since 2012, 2 transgender and gay-friendly health centers were established in Denpasar City to promote better linkages to early diagnosis and care. Fifi is now the coordinator of this initiative, whose main task is to inviting transgender people to undertake HIV and STI testing at the designated health center. These circumstances have allowed Fifi to be in regular contact with health services that cater her needs. So what can we learn from these 2 case studies? While Asana and Fifi are both suffered from gender oppression and heteronormativity norm within the Balinese society structure, Fifi is situated in a relatively privileged social, political, geographical, and economic location in comparison to Asana. For example, the availability of joined-up and transgender-friendly health services in Denpasar City, ongoing support from donor agency and local NGOs, creating political pressure, as well as political commitment from the local government. Extensive social networks and peer support groups in Denpasar City, access to economic opportunities and stable job for Fifi, recognition from health professionals leading to less stigma and discrimination. These relatively put Fifi in a very fortunate position in comparison to Asana's. Asana narrative, on the other hand, is quite the opposite. The story of multiple oppression from families, from society, from health officials, from health bureaucrats, and her disadvantaged and social and economic position leading to her premature death. By connecting the microanalysis of the lived experiences and microstructural and political determinants, this case study is able to disrupt the common belief that the transgender people is a homogeneous entity. They are, in fact, a diverse group with different needs, different risks, and different predisposing variables. Transgender people do not fall into singular category, as revealed through my case study, but rather complexly intertwined between class, social networks, job stability, social norms, geographical location, and health system. These systemic risks are not equitably distributed. Some transgender people experience greater oppression than others because of their social location and existing power structures operated within them. Access inequities are shaped by personal attributes as well as social dynamics operating simultaneously, where people can experience privilege and oppression at the same time. And action to redress access inequities must be reoriented to reflect this intersectionality that links individual experience and the broader structural factors. Why intersectionality beneficial? So it provides critical value to the analysis of multifaceted structural determinants. It also concentrates on the relationship and the interaction between multiple factors and across multiple levels of the society. And intersectionality analysis has transformational aims to give voice to those most excluded by reorienting power relation. These 2 case studies that I presented earlier highlight the need to disentangle these intersecting systemic risks to address health inequities. By applying an intersectional analysis, connection between individual attributes, institutional arrangement, and structural determinants in a given socio-historical context can be explicated. These insights are particularly important in any attempt to address social inequity and to promote social justice in Indonesia. So returning to the case of Asana in Jembrana district, her class position, gender, the patriarchal society in which she lived, pervasive moral and religious values, and lack of economic opportunities all increase the magnitude of social suffering and social neglect that she experienced. The notion of risk and moral governance, for example, conflate in Asana's lived experiences, creating greater structural and institutional barriers to access health services that she needs. So what are the mechanisms? There are at least 3 proposed mechanisms by looking at these 2 case studies. So the first one is that social location of Asana at the intersection of patriarchal structure, gender norms, and risk group discourse underpinned by moral pathology rhetoric has led to her exclusion and marginalization from the public health system.
Permisi 5 minutes, Pak Sutarsa.
Yes, I will be finished before that. Thank you. So the exercise of control by the health bureaucrats on the basis of the risk group, moral pathology, and socio-religious belief has justified the notion of horizontal equity as the legitimate goal of the public health system. And transgender people through the risk group discourse and moral pathology rhetoric are considered to be socially endangered, socially sick, and deviant groups. They become the subject of surveillance, as I mentioned earlier, not only public health surveillance, but also moral surveillance. So how intersectional analysis can promote equity-oriented health system? So the first one is that it provides deep insights to the underlying causes of access inequities experienced by the marginalized groups whose lives are at the intersection of various systemic oppression systems. The new framing of the policy problem will shift the primary focus of the health system intervention, and also in providing health services to the individuals, the conception of health must be situated within social relation and locate health within society and communities beyond the individual bodies. And to conclude, I would like to highlight 4 key points in this particular presentation. So the first one is that inequitable access to essential health services is again not random, but rather a systemic process mediated by institutional arrangement, socio-political determinants of health, and the ways our society is organized. With the emergence of COVID-19 pandemic, the interconnected systemic risks affecting people's access to healthcare are becoming more visible than before. Secondly, without a deep reflexivity to situate access and health inequities within proximal and systemic risk, problem and intervention will be framed in a reductionist manner, leading to fragmented action by the health system. Thirdly, ensuring access to affordable and comprehensive health services, therefore, requires intervention beyond the individual level to include these interrelated structural determinants. And the last point that I would like to make is that applying an intersectional analysis allows better reflection on the differential experiences of population, and in turn will improve the ways of formulating health and policy problems and their solution. So that's the end of my presentation, and I'm really looking forward for the discussion. Thank you very much.
Thank you very, very much, Pak Sutarsa. I would now like to welcome our second speaker, Ibu Professor Adi Utarini. Ibu Utarini, the screen is yours.
Assalamualaikum warahmatullahi wabarakatuh. Good afternoon and selamat pagi to our Indonesian colleagues. And thank you, Christine, for generous introduction, and also to the Indonesia update for giving excellent opportunity to present our work in eliminating dengue in Yogyakarta. I will share my screen now. Yes, is it seen? Yes. So dengue is not neglected in Indonesia, but continue to threaten a lot of people. The disease was present in 1968, and since then it has been escalating with several peaks. To control dengue, several interventions have been in place, which largely rely on factor control and community participation. Despite the effort, the disease is stubborn. Therefore, the Ministry of Health this year strengthened the program in a more strategic way through developing the first national strategy for dengue control 2021 to 25. It is expected that this sixth strategy will be a comprehensive strategy once implemented to fight Aedes aegypti, a stubborn mosquito. However, despite all the efforts, we still live in harmony even with many mosquitoes around us. Aedes aegypti is stable throughout the year. Their ability to reproduce outweigh our capacity to reduce their population. Our intervention, therefore, aims to make the mosquitoes safer to prevent them from transmitting dengue disease to humans. Wolbachia is an intracellular bacterium that is present naturally in around 60% of all insect species. And this is the intervention that we use. The video, please.
The mosquito known as Aedes aegypti originated in Africa. Over the last 400 years, it has spread throughout all tropical regions of the world, transmitting viruses to people. We are working on a way to stop this mosquito from transmitting dengue. Our method uses naturally occurring bacteria called Wolbachia that live inside insect cells and are passed from one generation to the next through the insect's eggs. Wolbachia are found naturally in up to 60% of all the different species of insects. Insects that include fruit flies, moths, dragonflies, and butterflies. The secret to the success of Wolbachia is how it manipulates the reproduction of the insects it lives in, so to give itself an advantage. It works like this. If a male insect has Wolbachia and mates with a female that doesn't, then the eggs she lays won't hatch. If the female has Wolbachia and the male doesn't, she would lay her normal number of eggs. They would all hatch, and all offspring will carry Wolbachia. When two insects that both carry Wolbachia mate, the eggs will hatch, and all offspring will carry Wolbachia. Over a few generations, the number of individuals carrying Wolbachia increases rapidly until nearly all the insects within a population have the bacteria. We wanted to see if we could use Wolbachia as a way to stop dengue transmission. To do this, we first had to move Wolbachia into the mosquito so that it would grow and be passed between generations. Using microscopic needles, we took Wolbachia from the fruit fly and injected it directly into young Aedes aegypti eggs. It took us thousands and thousands of attempts, but finally, we were successful. We then took the mosquitoes that contained Wolbachia and infected them with dengue, and found something really exciting. The virus didn't grow well in the mosquito, and if it can't grow, it can't be passed between people.
Thank you, and I will now return to my slide. I hope it is seen already. Yeah. So in the field, Wolbachia infected mosquitoes are released for a period of weeks or months, depending on the size of the area. They mate with the wild type Aedes aegypti, and the Wolbachia prevalence increases in the mosquito population and continues to increase even after releases stop, until nearly all the local Aedes aegypti carry Wolbachia. Wolbachia is then sustained in the population for years to follow without the need for reapplication. In Yogyakarta city, we use a small container to deploy Wolbachia Aedes aegypti eggs. The release is done fortnightly in all areas of Yogyakarta except health facilities. with certainly prior approval from homeowners or offices. And nowadays we have what we call it a mosquito foster parents. It is in a way that it is a two-way protections. We ask the community, the offices to protect the bucket, and hopefully we hope to protect the community from getting dengue. Let's see a bit more of the video. So the video, please. Thank you.
Ya, oke. Jadi kalau di lab sendiri kan sebetulnya di sini ada 3 fungsi. Satu adalah mempersiapkan memproduksi nyamuknya, yang kedua adalah mempersiapkan untuk penyebaran ke lapangannya, yang ketiga adalah bagaimana kita memonitor perkembangan nyamuk Wolbachia yang ada di lapangan. Setiap hari hampir ada misalnya nyamuk-nyamuk yang masuk, sampel-sampel yang masuk. Jadi teman-teman di sini bagaimana melakukan identifikasi, processing, terus bagaimana merecord datanya dan lain-lainnya sehingga masuk ke dalam data, terus nanti keluarnya adalah bagaimana kita peta sebaran Wolbachia. Karena itu sangat penting. Jadi biar nanti proteksinya merata gitu. Jadi di daerah disebari ada masyarakat yang sebetulnya jangan dulu deh, aku nyamuknya udah banyak dan lain-lain. Bahwa memang akan bertambah nyamuknya, tetapi ini juga suatu bentuk bagaimana kontribusi masyarakat Yogyakarta terhadap terhadap teknologi ini, bahwa teknologi untuk mengurangi terjadinya dengue. Tetapi paling di sini masyarakat juga di sebaliknya di daerah kontrol juga ada masyarakat, kenapa kok di tempatku nggak disebari gitu, nggak puas gitu. Tapi kembali bahwa tapi kan sebetulnya dari proses ke diskusi-diskusi sebelumnya bahwa sebetulnya manfaat ini akan diperoleh oleh siapapun pada wilayah Yogyakarta, cepat atau lambat. Ini teknologi yang one shot application. Jadi sekali dilakukan itu kita sampai Wolbachia stabil di situ, kita nggak perlu lakukan intervensi lagi sampai batasan waktu tertentu misalnya. Tetapi ketika kita nanti akan diaplikasikan atau itu dikembangkan di daerah lain, itu sudah tidak batasan riset lagi, tapi ke implementasi. Kalau pertanyaan apakah itu bisa, memungkinkan, bisa.
Right, I will return to my slides. Yeah, so once it is released in the community for a certain period of time, in our case is about 6 months in total, we stop the release. And in all areas, Wolbachia is able to sustain. Now this just to give the illustration to you, when we started in a pilot areas, this is 4 pilot areas. Each area has about 2,500 to 3,000 people. And this just shows the graph that even up to now, Wolbachia is able to sustain. Certainly our ultimate step is to provide evidence of efficacy. To what extent that this technology may be able to reduce dengue incidence in the community. So through cluster randomized control trial, we call this study ODD trial. In Bahasa Indonesia, we pronounce it AWED. AWED is actually means sustainable. So the application Wolbachia to eliminate dengue, the primary outcome is to show the efficacy of Wolbachia deployments in reducing the incidence of virologically confirmed dengue or VCD of any severity and also all serotypes. We have about 24 areas or clusters, we call it, and half of the areas we deployed Wolbachia, and half of the rest are the control areas. 54,000 patients presenting with fever to 18 healthcare clinics, primary healthcare clinics were screened, and we have about 8,000 of whom met the eligible criteria. At enrollment, the participants also, location was also recorded on the map. And they were asked about movements to capture the mobility in the 10 days prior to the illness onset. And then after the enrollment, we phoned the participants at 14 to 21 days and asked them whether they are okay, they are still alive, or whether they had been hospitalized due to dengue. And the result, here we show the efficacy of the result. And we have the 77% efficacy of Wolbachia intervention against virologically confirmed dengue. And in all 4 dengue virus serotype, this we all detected in the trial, but predominantly with serotype 2 and 4. And there was no evidence of the difference in efficacy across the serotypes. Additionally, and also interestingly, Wolbachia intervention appears also to be associated with the reduced rate of hospitalization due to VCD, due to dengue. And here in this case, we have 86% of reduction of hospitalized VCD cases in the intervention areas compared to the control areas. And then this result and also results from other WMP countries were presented to the Factor Control Advisory Group in WHO. And then Wolbachia was already recommended for WHO to develop guidelines for its implementation. The journey in this study would be impossible without great support from the community, from the local stakeholders, our collaborators, Monash University, WMP Global, and certainly our funder, Tahia Foundation. Approval from the community and local government are mandatory prior to the deployment of mosquito eggs. The critical point is for the community to understand that this intervention complements the dengue control program activities and not meant to replace the existing control activities. And women cadres obviously play a very pivotal role. A two-way strategy in building community trust was used. We aim to also bring the community closer to us to see the project facilities. These are women cadres. They came to our diagnostic lab, they came to our entomology lab, and also the other way around for us to be present, working in the community in a more attractive way. And working with media is one of our biggest lessons in this study. I think throughout our journey we learn and we use different strategy, from small direct face-to-face strategy to a more public campaign type of activities using different medias. The journey has been long and a phased journey for more than 10 years. With all the team leaders and researchers I'm very proud of. And we feel that we have shown our best effort for this study to be successful, despite all the challenges we faced since the journey began. Finding the right way, the right pathway to do the study was apparently not so straightforward process. There are so many doors we need to knock at both the central and the provincial level. And with our passion, we dealt with several ministries, Ministry of Agriculture, Ministry of Health, Research, Technology, Higher Education, and more institutions at the local level. Likely for one single intervention to prove, actually it takes multiple innovations in place to conduct the study beyond the capacity building also for our team in the beginning. And just to name a couple of the several innovations that we did, for example, this understanding of individual consent, which is not so applicable in this research. And then we were able to discuss, have deeper understanding, and then finally apply the community consent. And then independent risk analysis was also performed at the national level just before the trial was implemented. For us as researcher, it's also new for us to learn how to work with the medias and how to train ourselves and to speak to the medias in a frank way, and building communication with the media. And certainly the role of medias in this project has been very important to raise awareness and getting acceptance. In the technical part in doing the study, what we did in the study obviously was not possible to do a blinding. So what we did was public randomization, which is a new also method that we did. And last but not least is also the venture philanthropy, which is done by the Tahia family. So in summary, the ODD trial has successfully demonstrated high efficacy of Wolbachia infected mosquito deployments in reducing dengue incidence and hospitalization. Now, significantly, this trial is the first trial targeted at Aedes aegypti mosquito with the disease endpoint. An independent economic evaluation has been conducted, and has predicted that actually the Wolbachia deployment would be cost saving in high density urban areas of Indonesia. Thus, this is the case of one investment with sustainable intervention and effective result, ideal for public health innovation. We are now in the implementation phase of the project, and we currently implement this innovation not in a research mode, but we try to work with the Sleman and Bantul district health offices in order to integrate this Wolbachia intervention into the current dengue control program. We hope to be able to continue working on this, and we ask your involvement and your support to join our advocacy to the Indonesian government in order to protect more Indonesian people from getting dengue. Thank you very much.
Thank you very, very much, Ibu Professor Utarini. Ladies and gentlemen, I'd now like to welcome our third and final panelist for today, Ibu Dia. Please, Ibu Dia, the screen is yours.
Thank you, Kristen. And good afternoon, everyone in the other side of the globe. It is still morning here where I am. Thank you, Indonesia Project, for inviting me to be part of this very prestigious annual conference. And I would like to present a case of Puspa intervention in West Java. So I would like to begin by starting from the global level, which brings the question to every one of us: what does the world need for health, in health? The WHO presented our global program of work 13, which said that 3 billion people must be saved, the lives of 3 billion people must be saved once this global program of work cycle ends by 2023. There are 3 pillars. One is the universal health coverage, which will save 1 billion. Health and well-being will save another billion, and health emergency pillar will save another billion. So a total of 3 billion should be saved in a cycle of 4 to 5 years. To deliver that plan, I would like to point out to a very important global action plan on SDG 3, which is SDG in health. This is a collaboration between WHO and other 11 development agencies and UN organizations, which promise to accelerate delivery of the SDG 3 through 7 accelerators, one of which is primary healthcare, and the other are written on the screen. sustainable financing, community and civil society engagements, determinants of health, innovative programming, research, development, innovation and access, and data and digital health. Specifically for primary healthcare, it is the most equitable, efficient, and effective strategy to enhance population health. It will surely expedite and drive the delivery of healthier populations, universal health coverage, and health emergencies. In the Astana Declaration back in 2018, October of 2018, the WHO, along with the World Bank and UNICEF, presented this operational framework of how to deliver the SDG 3 and universal health coverage, and ultimately health for all through operationalization of primary health care. The approach is leveraged with the levers, and then PHC is going to have certain results which will improve access, utilization and quality, improve participation, health literacy and care seeking, and improve determinants of health. However, the pandemic hit, so the global program of work was delivered and officiated by member states of WHO in 2018. But then 2020, the pandemic hit. And the impact of the pandemic, it has caused 90% of countries reporting disruptions in essential health services, also in immunization, NCD, family planning, and reproductive health. And this is also a shadow pandemic in itself for women and girls, and mental health. Disruption occurs due to the decrease in demand. So people do not stop accessing healthcare, availability of health workforce, budget, of course, and also PPE. Therefore, when we re-examine and recalculate the delivery of the triple billion goals, this is not yet counting the impact of COVID itself. By 2021, in the beginning of 2021, the universal health coverage is still very short, 300 million people. Health emergencies protection only cover 516.19, and healthier population covers only 636.17 million out of the whole billion each in each pillar. Now, if we take that context into the pandemic in Indonesia, you can see here that now the number is 4.1 people infected, and the government reported death toll is 415,000 lives. And DKI Jakarta and West Java are two of the provinces with the highest number of confirmed cases. The strategy that is being observed from the outskirts of the government is that since the first case reported, the government never fully activated the health quarantine law. Partial restriction of mobilization is chosen as the method of containment. And by November 2020, 98% of cities and districts in Indonesia already have confirmed COVID cases. The response policy in Indonesia is prioritized on curative efforts. It's building and repurposing emergency hospitals, adding more hospital beds and ICU beds and facilities. Testing services focus on hospital-based and clinical laboratory-based, and it has a limitation in universal access to tests for suspect and close contacts. Until mid-2022, which is next year, indicators to assess response performance are based on the number of confirmed cases, deaths, and hospital occupancy. Meanwhile, the surveillance response, which is testing and tracing and isolation, are not the main indicators. We take note that the primary healthcare role, the modality which is one of the strongest modality in Indonesia health system, is neglected in the pandemic response. While Indonesia has 11,000 health centers or puskesmas with 34% inpatient facilities. The PHC system in Indonesia is an integration between public health function and primary health services, and it integrates different health programs such as maternal and child health, NCD, non-communicable disease, and TB. Puskesmas also now is widely using a family folder data, which was a product of the approach instituted by the Ministry of Health, I believe in 2016-2017. What should we do to ensure pandemic response in primary healthcare? It is being repeatedly mentioned by my colleagues in WHO that primary healthcare promotes equitable recovery from COVID-19 and accelerate progress towards the 3 billion and SDGs. So if we focus on primary healthcare, not only we deliver an equitable recovery from COVID-19, but also at the same time, we will deliver the 3 billion and achieve the SDG. Taking that background, context, and evidence from global level, Center for Indonesia Strategic Development Initiatives, or CISD, then adopted that frame of thinking into designing a COVID response action in primary healthcare, focuses on primary healthcare. It focuses on layers of governments from the global level, national level, city and regency governments, down to the health facility and communities itself. As a result of, then CISD conducted a pilot last year in 8 different locations in Bandung, West Java, and Jakarta. And as a result of that pilot was then upscaled into provincial level program of the provincial government of West Java. It covers 100 primary healthcare facilities in 12 districts in West Java and with an outreach of 7.25 million people, which attributed to 84% of COVID cases in the whole province. It's an integrated approach in primary healthcare, taking note, a very fine reference to the operational framework of the Astana Declaration in primary healthcare. And it strengthened, the ultimate goal is to strengthen the role of primary healthcare in COVID-19 response, with COVID-19 response itself as the center or as an entry point, health worker collaboration among sectors and actors, evidence-informed practice, protection and early warning system, and modification of essential care delivery. The indicators to achieve, there are 2 layers of indicator. Process indicator to reach people, health center, ensuring PPEs and tests are being distributed equitably. And there are also the output indicators to be achieved during the period of intervention of 6 months. The process is, of course, very detailed, but we conduct the feasibility study, model development, recruitment of 500 health workforce. Most of them are early career professionals, training the health workforce, deploying them to 100 puskesmas in 12 districts in West Java, doing a monitoring with a dashboard and M&E plan, and then conducting impact assessment in the end. After 6 months of intervention, the results are as follows. When the team first came, the number of cases was really very high, and then all of Indonesia experienced a high surge in the middle here, end of June to beginning of September. And then now we are already down in the cases. In the testing, initially it was very low. It's below 1 per 1,000 people per week tested, and now most of the districts have already achieved a higher percentage of testing. 55% of the Puskesmas achieved the target with an average of 1.74 per 1,000 population per week. Another pillar of the whole of society approach is the community-based surveillance. This is a methodology that was developed by the team to ensure sustainability in tracing, and that tracing is effective and it can reach not only the close contact, but the second layer or even the third layer of the close contact. It requires involvement of health volunteers, and in the 6 months of intervention, the program managed to reach out to 3,545 persons being volunteered to as tracers. Contact tracing result, 96.53% traced within 72 hours. This is above regional average, and the tracing ratio is 6% per close contact. So one confirmed case can reach 6.16% in close contact. In isolation part, Puskesmas owns the capacity to monitor self-quarantine, and during the high surge cases where the number of self-quarantine patients are very high, Puskesmas are burdened with cases and which need more advanced medical devices and advanced medical care. The lack of coordination in between Puskesmas at primary healthcare and hospitals resulted in many deaths in self-quarantine during the high surge. And most of the people who died in self-isolation or self-quarantine are not yet vaccinated. In the end of the 6 months treatment, all close contact conduct self-isolation, 98.46% is being monitored by the health cadres, the health volunteers who are involved in the community-based surveillance approach. That approach to empower the community also is taken, stretched further to ensure health promotion to vulnerable population with high risk, categorized as high risk population. It reached almost 800,000 or 84% high risk sentinel places. To ensure sustainability,
Ibu, 5 minutes, Ibu.
Yes, the PUSPA team also built public access dashboard to make sure that data is available for the public, and builds an ecosystem of supporters for PHC transformation, which involves private sector, student organizations, academia, and other organizations outside of health and also in health sector. The impact is improving primary health and community resilience in COVID response. 80% of the Puskesmas now applying community-based surveillance approach, and health workers and health cadres are trained, able to do the testing and able to do an active outreach to the community. The intended consequences of this intervention is to ensure that civil society and government are working together as equal partner. This will help the prioritizing of primary healthcare, which then in the end impact for a policy direction in the health system. I would like to end with posting a few questions After the 6 months of intervention and promising results so far, we are still waiting for the impact evaluation assessments done by the University of Indonesia and the Universitas Pajajaran to be finalized in November of this year, which will measure the impact of this intervention from program aspect and also from the economic or the budget aspect. But despite from those two elements, I would like to end with questions on what does success look like and what are the modalities to ensure success can be achieved, and what is the ideal approach in governance aspect. We face challenges in decentralization, but is it a driver or a challenge? And how can primary healthcare be leveraged to Indonesia's next role as president of G20 and its current role as co-chair in the COVAX AMC? And how can the West Java experience be utilized as evidence to improve health service and patients' experience in navigating the health system? I thank you. Terima kasih. Semoga bermanfaat.
Terima kasih banyak, Ibu Dia. And thank you again to all of our panelists this morning, Ibu Dia, Professor Utarini, and Pak Sutarsa. Ladies and gentlemen, we now have time for questions and answers. And as I mentioned before at the beginning, there are two ways you can ask questions. On Zoom, it's through using the Q&A box or by clicking the raise your hand icon. And on YouTube, this can be done through writing your questions in the comment box. And we actually have a first round of questions. So thank you very much to those who've already submitted your questions. The first two are directed towards Pak Sutarsa, and the third one will be for Professor Utarini. So I would like to ask Mr. Dennis O'Day. I think he would like to ask a question of Pak Sutarsa. So over to you, Dennis O'Day. Maybe Dennis is... Okay, while we're waiting for Dennis, I might just ask the second question because it's one that I've been asked to read out. It's on behalf of Liza Munira. Her question is, she said, thank you very much for the presentation and for presenting the contrast between Asana and Vivi. We also learned from Professor Laksano's presentation yesterday that utilization of health service is also unequal. A general assumption is that improving universal healthcare, JKN in Indonesia, would help increase access. She's asking, could you please share some insight on whether there's anything specific that the JKN program in Indonesia needs to get right to enable access for other people in other asanas in Indonesia? So that one is for Pak Sutarsa. And then for our third question, while we're waiting for Dennis, but that is from our co-convener, Ibu Arian Utomo. Ibu Arian, I'll throw to you to ask your question for Professor Utarini.
Thank you so much for your presentation, Prof. Uut. My question is, we've heard news about recent outbreaks of dengue in India following their high numbers of COVID cases. Do you think this will be an issue in Indonesia? I'd like to hear your thoughts on that. Thank you.
Great, thank you so much. I'll just see if we have... Oh, I'll read out Dennis's question shortly, but while I'm getting that question, I'll throw to Pak Sutarsa if you would like to respond to the question from Liza Munira.
Yep. Thank you very much, Kirsten, and also thank you very much for the question, Lisa. So as we heard yesterday from the presentation, indeed the implementation of Indonesian Health Insurance Scheme, or we call it JKN or BPJS Kesehatan, is not guarantee that all Indonesians will have equal access to health care or health services. So this assumption is partial. So having access to health financing does not directly translate into equal access to healthcare facilities. So because we need to looking at the existing infrastructure of health system across Indonesia. So Indonesia in east part of Indonesia, for example, if we compare with the western part of Indonesia, they do have unequitable distribution of health resources. They have inequitable distribution of health workforce and also health resource in general. So having the same access to health financing will not translate directly to equal access to healthcare facilities. And there is also the notion of horizontal and vertical equity that we need to take into account. So while promoting horizontal equity is important, but we also need to take into account different layers of risk across the Indonesian population. So therefore, vertical equity is also important while we put forward implementation for JKN. So some action can be promoted. So for example, we need to promote tailored model for distribution of health resources, for example, because some areas they do need more resources in comparison to other areas. Other issue that we need to take into account is we need to address the inequitable health infrastructure to begin with. And also we need to address the general infrastructure inequitable in general infrastructure across Indonesia to begin with. Then we can talk about equal access to healthcare facilities. It's a big homework for Indonesia, and there is no silver bullet to make utilization of health services to be equal across Indonesia. But there is a way, there is a pathway that we need to consider along the way. So I'll stop there, Kirsten.
Great, thanks, Pak Sutarsa. Professor Utarini, would you like to respond to Ibu Arian's question?
Yeah. So thank you for the question, Ariana. I think certainly this is an issue of worth exploring in Indonesia. Yeah, up to now, I think we've heard about hospital case reports of cases with dengue and COVID infections. However, I'm not so aware to what extent there's a study that is really systematically looking at these interactions of dengue and COVID in Indonesia. The problem with dengue and COVID is that there could be a delay in managing the dengue cases if at first the cases is suspected of COVID. And this could result in further delay for the public health office to do epidemiological investigation and do the public health interventions following a dengue case, for example. And that's also occurring at the community level. Certainly the factor control activities and the community participation is also discouraged with still the COVID pandemic in place. So there could be scenarios if we are not careful that this could potentially result in dengue outbreak. Fortunately, in Yogyakarta city and also Yogyakarta province generally, where the COVID is also, still at quite a high level. In our area of Wolbachia intervention, dengue incidence is still stably low. So, I think that's my response to Bu Ariana. Thank you.
Thank you very much, Professor Utarini. I now have Dennis O'Day's question for Pak Sutarsa. His question is, he says that the intersectional analysis was interesting. I'm interested in your views about a social economic analysis. What about those at the bottom 20% of society? So it's one for you, Pak Sutarsa. And I'll also have another one to read out from Dina Fauzia. Her question is to Ibu Dia. Why the number of case reports and community-based surveillance shows different trends in the graphs. Is it to do with the technical challenges from the community to report the surveillance data? So perhaps with those two, I'll throw back initially to Pak Sutasa and then Ibu Dia. Thanks, Pak.
Well, thank you. Thank you, Dennis, for the questions. Yes, socioeconomic analysis is important. But again, as I mentioned earlier in my presentation, looking at one aspect alone, it's insufficient because we will end up with fragmented or a partial representation of the reality. So we need to looking at the whole issues of access inequities from multiple angles. So because each oppression system, in your case is economic, for example, economic circumstances, is not operating in silos. They are intersect with different system of oppression. For example, being poor, but also being transgender, they will experience different access to health inequities as being poor and being male, for example, in the Balinese society. Or the other example could be being poor and HIV positive and living in rural areas across Indonesia. They will have very different experience in comparison to being poor but living in metropolitan Indonesian areas, for examples. So while it is important, we need to note that this oppression or economic oppression is not operated in silos. They are, in fact, intersected with other systemic risk, as I mentioned in my presentation. So I think that is why, rather than looking at the issues from a single lens, so my idea is actually to promote the use of intersectional analysis so that we can have a bigger, a fuller and more comprehensive pictures of the reality on the ground. Thank you.
Thank you very much, Pak Sutasa. Ibu Dia, over to you.
Yes, thank you for the question. The different trends in the communities in the graphs is because there are actually 100 variations in 100 puskesmas, because there are 100 communities that that is being faced with the pandemic. Unfortunately, those 100 communities contributed to 84% of the COVID cases. The challenges faced by each of the puskesmas are the same but yet different, mostly due to budget restriction that do not yet allow for puskesmas to be agile and to have autonomy or authority or their own agency to execute things that they think is best for their communities, and it impacts the consequence impacts the ability to reach out to the health workers, because some puskesmas are can develop innovative ideas to reach out and engage more health cadres and more volunteers, but others are being very strict and going by the book because they do in this pandemic situation is more or less chaotic, if I may say so, and the chaos is spread across communities, and communities are basically trying to find the best way they can to reach out to community health workers, to involve volunteers and health cadres. So communities that are more innovative, they can develop or have stronger network of health cadres already before the pandemic, then have shown a high number in the graph. But communities that just starting to build this network of health, community health workers and health cadres in time of pandemic face more challenge, and their stability and growth is not as fast. I hope that explains.
Thank you very much, Ibu Dia. Now for second round or third round, perhaps, of questions. We have two that will be asked live from our audience members. So first of all, I would like to invite Eliza Hunt. Eliza, if you would like to ask your question.
Thanks, Kirsten. My question is to Budia. Thank you for everyone for the presentations. I'm really interested to learn a little bit about the mental health outcomes and whether they've been incorporated into any of the Puskesmas programming by PUSPA. I mean, we all know that mental health outcomes are worsening, and I'm wondering about in terms of if there's any prevention, promotion or curative efforts around mental health interventions for PUSPA. Thank you.
Thank you very much, Eliza. I'll just get our second question, which I would like is from Pak Budi Reso Sudarmo. Pak Budi, over to you.
Yes, thank you very much for the opportunity. My question is for Professor Utarini. The question is that with this kind of treatment, could we expect a sustainability of the treatment? And second is that it seems to me that this treatment of dengue is by releasing an invasive species in a new environment. Do we have to worry about the issue of invasive species on this case? Thank you.
Thank you. Thank you very much, Pak Budi. So I'll ask maybe Budia if you would like to respond first to the question from Eliza.
Yes. Thank you, Eliza, for the question. I would like to briefly explain that the approach PUSPA takes towards communities is through Puskesmas and through health workforce, and then through community health workers, and then the public. So with that, because the public is 7.2 million. So it's really very a logical approach in this design to go with the health workforce first, and then transfer the support to who will then, we hope, transfer the support for mental health to the public. For health workforce, during the very high surge in COVID, in the middle of from June to August, at one point, 40% of the PUSPA additional health workforce were infected with COVID. Two of the supervisors passed away due to COVID, and this present a very high burden, mental burden, mental health burden to the health workforce themselves. So we opt to, given the limitation and the boundaries to what we can do to the public, we opt to support, provide support for mental health to the health workforce first, and the health workforce then transfer that support to the community health workers and hopefully to the public. But we depend a lot on the health workforce resilience and integrity in this case, so they can still deliver care at the same time taking care of their own physical and mental health.
Thank you very much, Budia. Professor Utarini, if you'd like to respond to the question from Pak Budi.
Yeah. Thank you, Pak Budi, for the question. I think those are two critical questions that people often ask. The first one is about the sustainability of the intervention. What we have in Yogyakarta, our first pilot release was in 2014. So now it's already in the 7th year. And we hasn't, and the release itself was only done for 6 months and then stopped after that. And our close monitoring up to now, we didn't see any drop of Wolbachia in the natural population. Similar evidence, I think, in Australia. There's an area in the northern part of Australia where they did this release. Now is already 11 years, and we've seen the same observation that the intervention is sustainable and there is no need for reapplication of the deployment of mosquitoes in the areas. And I think with the current evidence that with the ability to reduce 77.1% dengue incidence, this shows very, very high efficacy, very comparable to the dengue vaccine. The second issue on safety is something that we have been very concerned since the beginning of our project in 2011. And continuously during the different phases of the project, there are measures, serological surveys to the people where we first release the areas, as well as to our research staff who actually feed the mosquitoes with our blood. And we look at there's a serological evidence whether Wolbachia can be transferred into the human body. And one of the key activities, and this was initiated by the Ministry of Research Technology in collaboration with the Ministry of Health, that was before we did the large-scale deployment in Yogyakarta city. The ministry established this independent risk analysis committee consisting of experts from different fields, from different institutions in Indonesia. And through their processes and exercise and intensive discussion, they then concluded that the risk due to Wolbachia intervention is negligible, which is the lowest risk level. So we are still continuously with our effort to make sure that safety is not an issue. Although I think from the beginning we always try to explain that Wolbachia itself is a naturally occurring Wolbachia. But thank you for raising this issue.
Thank you very much, Professor Utarini. So I think we have time for one last round of questions. And we have two. One is directed to all the panelists, and it's from Avi Mahaningtyas. Avi says, with the lack of public health system access and government policy, what actions do the community and regional governments need to live with the possible third wave of the pandemic? Would it be sufficient to rely on the kindness and neighbour help neighbour approach? Is there any wisdom from the presenters for Indonesia, but particularly communities and regional governments in potentially facing a third wave of the COVID-19 pandemic? And that the question is actually from me, and as chair, I take the opportunity to direct a question to Professor Utarini. Professor, I was interested to hear you talked about the challenges and opportunities of working for such a long time on an innovative research and policy initiative. You mentioned particularly the importance of community engagement and working with media, but I know you've also mentioned some of the opportunities but challenges of working on a multi-level government policy dialogue process. So just interested in some of your insights, or the key challenge that you faced in navigating a multi-layered government policy dynamic that we have here in Indonesia. So first of all, I maybe to respond to Avi's question about from the panel, and maybe I'll throw to Pak Sutasa first, your suggestions about approaches potentially for managing a third wave of the pandemic here in Indonesia. Thank you.
Thank you very much for the question, and it is very important question, really. So how we can prevent the third wave, or if not the fourth wave or fifth wave of pandemic in Indonesia. So I think you mentioned a really key point over there in relation to this, Afi. So the community system strengthening is one of the key measures that we need to leverage to prevent this pandemic. So we learned from the 2020 pandemic, for example. We're not swift enough to leverage the community system, the role of the community system in preventing the pandemic. And the Indonesian contexts are very diverse. So I think Mbak Dia mentioned even Puskesmas, they do have their own context, and we need to take into account the diversity across Indonesia. And we need to leverage this community system that organically form within the society as a front line of the COVID-19 prevention strategy in the future. So yesterday, Prof. Laksono mentioned the critical values of health system strengthening, but I also argue that health system strengthening need to be accompanied by the community system strengthening to prevent further escalation of the pandemic in the future. Thank you.
Thank you very much, Pak Sutasa. Ibu Dia, would you like to respond to that question also?
Yes, thank you, Ibu Afi, for the very deep question. I think there are two elements and there are reasons why WHO said the whole of government approach and whole of society approach. Those two must work together in collaboration, hand in hand. If one is not working, then the other one cannot substitute or supplement, because each one, the society and the government, has their role, very important roles that they play in, that they must fulfill. That is not to say that helping neighbors have no impact. Helping neighbors always have the impact, especially during pandemic. However, if we question, if we ask about sustainability or ability to prevent and ability to prepare for the next wave or the next pandemic, then it needs policy, strong policy from the government to be able to ensure that neighbors, helping neighbors become regulated or becomes part of the regulation and one of the best variable of policy making. By saying policy, I do not mean only policy at national level. I also mean policy at regional and sub-regional level even, which needs to be in sync and reflect each of the different layers, because different layers of government have different functions again. And this will, strong policy guidance, strong policy direction will help community to sustain their efforts, and it gives them direction to the finish line, the impact that they want to achieve. And I think still both needs collaboration with each other. And also, I think there is an element of, especially now we are faced as a world with the same situation, with the same problem. Global policy now plays also a very important role, and the ability to navigate between global level to national level and adapt at community level becomes key in preventing the next pandemic and the next wave. Thank you.
Thank you very much, Ibu Dia. And now perhaps the final response for our session this morning with Professor Utarini in response to Afi's question, perhaps just incorporating as well my question, which I think is a bit similar in terms of some of the challenges and how to approach a potential third wave of COVID-19, including with all the different levels of government and actors that are involved. Thank you. I'm interested in your response, Professor Utarini.
I think the approach is to be persistent and to keep trying to update the key stakeholders. So we have a list of we did a stakeholder approach analysis and trying our best to keep communicating and updating the stakeholders as we go along. But also, I think for me as a researcher, if there's a clearer sort of pathway, how to help us in order to make this research more useful for others, that means that somehow it has a policy component in it. And if there's a clearer pathway, what should we do? Where should we go? And what are the steps? Perhaps this would make it easier for us. But otherwise, I think in a different timings, different phase of the project, the national stakeholders, different ministries have been very supportive to this research and shown their interest also to this research. Thank you.
Great. Thank you so much, Professor Utarini. So thank you, ladies and gentlemen. I think that brings our session to a close for this morning or this afternoon or this evening. I'd just really like to say once again, a very sincere thank you to our very esteemed panelists today, Bapak I Nyoman Sutarsa, Professor Adi Utarini, and Ibu Dia Satyani Saminarsi. I think all of our audience members would agree it's been a really fascinating set of presentations this morning, looking at issues from a range of different perspectives, but very much highlighting the complexity of navigating change within the health system in Indonesia. So thank you once again very, very much. Thank you also to audience members for all your great questions and the responses from our panelists. If people would like to continue to interact and discuss some of the issues that have come up during this morning's session, I would encourage you to enter into the virtual mingling, networking breakout room. I understand the link to access those rooms or that room is provided through the chat box. So I really encourage everyone, we don't get to meet in person, but I encourage people who have the time to go in there and take the opportunity to continue the interesting discussions. So thank you once again, and I wish you all the best for the remainder of the conference. Thank you.
Good afternoon, everyone. Selamat siang. Assalamualaikum warahmatullahi wabarakatuh. I am Ariana Utomo, and welcome to the third panel of the 38th ANU Indonesian Update. I am here today with our colleagues from IndoSpeak. We have Silva Penrisara Pertiwi Isma and Ramadhani Rahmi. They will be interpreting this panel to Bahasa Isyarat Indonesia. I would like to begin by acknowledging that those of us in Australia are meeting on the unceded lands of various First Nations people. And I would like to acknowledge the traditional owners of the land where I live and work, the Wurundjeri people. And I would like to pay my respect to the elders in the past, present, and emerging.
Recording in progress.
Now, in this panel today, we have two speakers who will discuss the challenges and innovation pertaining to data collection, data management, and disease surveillance within the context of health transition in Indonesia. Each of the speakers will speak for about 20 minutes each, and then we will have a combined Q&A session for another 20 minutes at the end. Please have a look at the different ways that you can participate in the Q&A in the chat. Thank you. So it is my pleasure to invite our first speaker, Professor Terry Hall from the ANU School of Demography, to speak first. Pak Terry, as many of us call him, was the president of the Asian Population Association for the period of 2013 to 2015. And currently in his position as Emeritus Professor, he is attached to the School of Demography in the Research School of Social Sciences at the ANU College of the Arts and Social Sciences. Silakan Pak Terry, the screen is yours. Terima kasih.
Thank you very much, Ariane. I appreciate the invitation to speak at this very important Indonesia update. I've been amazed at the wonderful use of Zoom to include so many people who might not have been able to attend an update in person. Certainly no one from outside of Canberra would have been able to. And even in Canberra, we're not able to go outside of our houses. So I appreciate your time, and I will be reviewing some of the issues about health data. Many people have an idea that health data is about births, deaths, and the time in between. I'm going to be looking at two aspects of health data in Indonesia that are quite important. One is the incredible complexity of the structure of health data collection. It's not just at the puskesmas or at the hospital that health data are collected. Health data are collected also by the Statistics Indonesia, the BKKBN, the Ministry of Home Affairs, and many other ministries have data that we often use to understand health trends. The multiple sources of data collection have a problem associated with them if they do not reflect the same numbers. And for this reason, later we'll be talking about the One Data initiative in Indonesia. The biggest problem from my viewpoint, though, as a researcher, is the bureaucratic resistance to open data dissemination. It's quite difficult to get access to the health data we need to do the analysis of almost anything we want to look at. And we'll be looking at that in particular with regard to some of the Ministry of Health data sets. But for me to understand health data, I'd even like to go back a couple of hundred years to some of the first censuses in Indonesia, where population counts were used to get an understanding of the numbers and the rate of growth of people across the archipelago. Raffles, in his first census, relied not on a visit to each household to count people, but rather he asked the local officials. And what we will learn is that last year, during the COVID census year, we were thrown back to the same methods that Raffles used because we were unable to visit households to get the information needed on the people who were living there. Alfred Lord Wallace told a census myth about the Raja of Lombok, who he said had asked all the individuals in the land to send in one needle, and he then used the accumulated needles to make a kriss. And he counted all the needles so he knew how many people were supposed to be paying taxes. Instead, he found that if people did not have a motivation to send the needles, he knew he would not be getting his taxes. So the motivation was that by turning the needles into a kriss and using that kriss to cure pandemics by taking it from village to village, he would get people to give the correct information. Since that myth, we've had a rise of scientific censuses. And over the 20th century, Indonesia developed a range of health data initiatives from the hygiene study wards in the 1930s through to the Riskestas, which we heard a little bit about earlier, and epidemiology. And then we also have family planning data sets run in connection with the BKKBN. Now, the population health data is looking at the three components, the absolute numbers of denominators and numerators in order to understand population. the national censuses from 1961 through 1990 asked only a sample of households the detailed questions they needed to know about characteristics of population. But in 2000, 2010, and then in 2020, the government was able to try to go to each household and get a full count of the entire nation. The 2020 plan was disrupted by the COVID-19 epidemic. And we now look back to see not the failure of government, but the failure of the plan to stand up to the threat of COVID. There was to have been a large sample survey as well in 2021, but that has been put off at least until 2024. President Joko Widodo has developed the concept of satu data, the idea that all government officials should be using the same data numbers in their planning so that we don't get contradictions between the different sources of information. The full count census was meant to have that satu data idea by having the BPS work collaboratively with the Ministry of Home Affairs to collect all the data. The great initiative of the 2020 census was a large effort to get digitally submitted data where people could go online, even using the cell phone, to try to fill in the census forms. This is a screenshot of the dashboard of that digital activity. When about halfway through, it was when 13.88% of the households had filled in the digital data. And you could see that BPS was in the process of following all of the submissions and understanding something about the data as it was being collected. Unfortunately, this one from the 22nd of February was one of the last interesting ones because soon after, as people remember, the COVID shutdown occurred. In September, the BPS was going to have interviewers going house to house to fill in the forms for anyone who hadn't been able to do the form by the digital means. They had to have special face masks, masker, and gloves so that they could have a healthy visit to households. But as you can imagine, even though that was kicked off on September 1st, within a few days, the interviewers going from village to village found that they were not able to visit the households because the village heads wanted to ensure that the virus did not come in from outside. I found this North Sumatra photo disturbing because nobody's wearing face masks and they're not keeping much of a social distance. The whole idea of preserving people's health during the census collection was undermined by this kind of activity. But the BPS did have a lot of volunteers and others who did try to collect the data. However, by the end of the second data collection when the results started being processed, it was quite clear that there were real problems. The total population was released on the 21st of January, 2021, and gave a population of 270,203,917. That preliminary result was included an age distribution that was provided by the Ministry of Home Affairs. The result was somewhat surprising because it showed a lower population growth rate, but also a very small number of 0 to 4-year-olds, children. It looked like children were undercounted. You can see on this population pyramid that the heavy dark line is the 2020 result compared to the numbers from 2010. That smaller number of 0 to 4-year-olds undermines our attempts to estimate fertility and also mortality. When we look at this age-sex structure, don't try and read the numbers, obviously, but you can see that the preliminary results and the final results, the revised results, show that there was a difference, quite substantial difference in 0 to 4-year-olds. And when you adjust for the new numbers, you can calculate and get total fertility. We estimated the total fertility from the preliminary results. It would have been 1.5, a remarkable low total fertility rate. Once the adjustment for the age distribution, we get 2.1, which means Indonesia has replacement level fertility. That was the original goal of the BKKBN. We can congratulate them on meeting that goal. But you can see that the first result using data from the Ministry of Home Affairs and the revised result is quite substantially different. The ratio of people surviving between censuses for different cohorts is an extremely important element of estimating expectation of life. What is remarkable here is that the ratio surviving after 2010 into 2020 for these different age groups is greater than 1. So we've got people appearing from nowhere into these cohorts. This is very disturbing, and I'm sure that my friends and colleagues at the demographic institutes across Indonesia will be spending a lot of time trying to figure out how much of this is because of returned TKI atau TKW who have come back from overseas in 2020, and how much of this was because of errors in the count. And so we're going to have to keep our eyes on that. My first conclusion about the situation is that COVID-19 disrupted all of the data systems last year, whether it was the BPS biggest data collection of ever in Indonesia using the census, or the Ministry of Health and the BKKBN trying to collect routine data on various health activities. The census itself had a budget cut of from $1.03 per capita down to 26 cents per capita. That is a huge cut in the middle of a data collection. The digital collection proved itself to be feasible before the pandemic hit it. And I'm sure that BPS eventually will go back to that method of data collection. But the field collection was very much disrupted, and I'm thinking that the clash between Ministry of Home Affairs and the BPS field interviewers is something that has to be dealt with in future. We are hoping that there will be a sample census next year, but it could be another 2 years. The data sets in the Ministry of Health were not only disrupted, but they're increasingly difficult to access. There are some wonderful web pages showing summary measures of a whole range of things, among which are 95% of births have birth certificates, according to the Ministry of Health website. The question is whether that 95% has the correct denominator, because if we have a large undercount of the population, and I would guess that it's probably around 10 million or even 15 million people, then all the numbers in the Ministry of Health data are going to be questionable. The Ministry of Home Affairs has a similar problem. The BKKBN, I keep looking, where is the family planning data? That seems to be gone, and now we have a stunting program in BKKBN. I don't want to be flippant, but it seems that the BKKBN is the one with the stunting, and the Ministry of Health has other ways of measuring stunting. The danger is that these blows to health data quality will last for years to come, and that will be a real case of long COVID.
Thank you very much, Pak Terry. That was perfect timing, actually, with more than almost 2 minutes left. So that's great. Terima kasih, Pak Terry.
Sama-sama.
Okay, so berikutnya. So next we will have Dr. Iqbal Eliazar from Eijkman Institute in Jakarta, who will be presenting a paper titled Challenges and Realities of COVID-19 Data Quality. Pak Iqbal earned his PhD in malaria disease mapping from Oxford, and he has been focusing on biostatistics, disease surveillance, spatial epidemiology, and malaria elimination strategies in the last 17 years. And I would also like to introduce the co-authors of the paper today. We have Irma Hidayana from Lapor COVID-19, Leni Ikawati from Eijkman Institute and Oxford University, Ahmad Arif from Lapor COVID-19, and Ahmad Nur Hasim from the Conversation Indonesia. Please do have a look at the full bio in the program that accompanied this conference. So, Pak Iqbal, monggo silahkan di-share screen-nya.
Terima kasih, Bu Arin. Sudah terlihat ya, Bu Arin? Okay. Good afternoon, everyone, and thank you for the committee. Thank you for Dr. Firman and Dr. Aryan for inviting us to the great presentation today, 2021 Indonesia Update. And I would like to share some stories, experience, and also the lesson learned during the 18 months of pandemic with my colleague here. Irma is here, Leni is here, and Dr. Mas Hasib is here also from the conversations. The title of our presentation is Challenges and Reality of COVID-19 Data Quality. Okay, The structure of my presentation will cover several topics, including the wave of COVID-19 data in general, and the national visions of data and information, and when the pandemic is coming, what happened with the visions, and also where to look the quality data. And we would like to make a separation about the data needs, transparency, presentation, how the discrepancy occurs, and also the absence of the essential data. And then the last topic that I would like to share about the lesson learned and conclusion about what we had in active pandemics in Indonesia, especially related to the COVID-19 quality data and some acknowledgement to our collaborators. So as you are already aware that the COVID-19 interactions actually affected many multidimensional elements, start from the vulnerable population and also the transmission even and also the case finding, detection, tracing, and also affect the public performance. And it also influenced the effectiveness of the communication and also bringing up the trust in authority and questioning also the accountability of the authorities. So from the all element of the COVID interaction, it generates a lot of data actually. One of them that we would like to share here is the testing data and the date data. That is the two elements that we would like to share today. Talking about the national vision, as Pateri mentioned, actually it started in 2008, where the president of SBY released the public information transparency. Actually, it's talking about open data. It's a mandatory to public entity or the government, central or local government, to release a public information regularly. And also, they built the information committee, which aim to ensure the system works. During President Jokowi, he also released the President's Decree 2019, One Data. And they are aware that the way to integrate the planning and all execution, evaluation, and monitoring between the central and the local government, they need high quality data. And the decree also mentioned about dimension of the data quality they are searched for, the accuracy, updated, integrated, accountability, easily accessed, data sharing, and sustainability. All the mention of data quality actually is challenged and is tested during the pandemic, when the pandemic is coming. When you see that the statement of the president in the mid of March 2020, the president, the leader of government, admitted the government concealed some information about corona. At the same time, we don't want to create a sense of panic and unrest in communities. Therefore, in hiding this, we are soundless. This is a kind of contradiction when we compare with the spirit, the open data, and also the one data. One month later, the president instructed the central and also the local government to be transparent about the data COVID. And he assigns the COVID-19 task force to carry out effective, detailed, good, and transparent communication to all. And I would like to cite the strong collaboration and openness of data between all parties is needed to be able to handle the outbreak. It will be easier to find appropriate policies to handle the COVID. So that is the statement in the Compass in April 2020. But what happened in 1 year after the instruction? So we are still dealing with the reluctancy of the minister or the government to follow the WHO guideline about the death counting. WHO recommended the probable death also counted as COVID-19 death, but the government remained at the position the COVID-19 death must be confirmed by the positive test. So it means that the number of the death counting in Indonesia is absolutely undercounted. WHO received, MOH admit that they also received the probable death numbers from the district and the provincial level, but they keep this number. So we would like to test it about the openness, transparency, and also the one data concept during our presentation here. Actually, in the March 2020, we already recommended to the government about the openness and transparency of the data, because the data will be useful to predict, to estimate the trajectory of the pandemic. And we also mentioned about to provide the data on patient location, because this information also vital to understand the tracking system, the distribution, the spatial distribution, and also to support the tracing system. We had mentioned in March 2020. And this article, I have a personal touch with this article. This is my first contact with the Hasim One, the senior health editor in the Confederation of Indonesia, and where he guided me to write the popular article. So this is the personal story of this article. And 1,500 readers read this article, and it gives a significant announcement to the article as well. Something happened between March, April, and May, where the government seems to play with the numbers. So when I said the number, because they didn't understand the fluctuation of the cases, it was heavily influenced by the number of testing. The number of when you had the testing increase, probably you will have the higher cases as well. But when you decrease the testing, you will have the declining of the number of positive. When you have a declining testing, it's not allowed for you to mention that the case is slowed down. So in May 2020, we reminded the government that Indonesia has not yet have the COVID epidemic. So we must to be careful to understand or to mention that the pandemic is slowed down. So we had several webinars, we read the letters, we had the article in the Confederation, how to make a curve, epidemic curve, as well how to interpret and how to give recommendation using the data. So this is the article that we wrote in May 2020. As you can see here, the COVID-19 data flow is complex. It started from the left side. You can see that the Puskesmas, hospitals, the reference hospital, and the surveillance system at the port, at the international port mainly. So they captures the patient there, and then input the data to the big data system. They call it unequal or record. And then they share the data with the laboratory, and if they find the positive, and they notify to the local or to the district or to the provincial office, and that will trigger the epidemiological investigation or the tracing or close contact monitoring. And all information will return to the new record or to the other application system. And this information will be released by the spokespersons of the COVID-19. This is the examples of the epidemiological investigation or the tracing form. It's a very complex clinical information there, and also they ask about the exposure factors and the close contact listing. But at the same time, we find there is a problem because there is no incentive or literacy. It means that probably the tracer did not understand fully what the purpose of the data is collected. And we find a high proportion of the missing data in the system. It's a pity actually, because a lot of effort and a lot of people actually go to the field to collect the data, but they did not complete all the data form. So the analysis will be is not sufficient. When you see the COVID-19 go.id, this is the COVID-19 dashboard. I would say this is excellent visualization, excellent data gathering, and I thank the government to release this kind of information. When I compare to other countries, they even don't have this kind of visualization, the COVID data set. But there is some what they call it. I need to be criticized about this one, because the dashboard, they didn't have the function that allow us to extract the download data to run the analysis, to run the further analysis. And also problem with the x-axis. That's why at that time they didn't utilize this information to have the epidemic curve, because the x-axis represented the date of events, case or death reported, not the date of onset, which is critical in generating the curve epidemic. The date of sample of taken is not there, and the date occurred is not there. They also relying on the date of event reported from the lower level to the central levels. And the most important thing is the testing data. I love for COVID, and I think majority of the scholars in Indonesia in the pandemic, they are very keen to look at the daily testing data, because it helps us to understand the real situation in the fields. There's no display at the daily testing data in the system. So we are not able to validate the real situation at the time. And there's a problem with the no probable death, even though the government admit that they collected the probable death in the system, but they are not released, but the government didn't release the information in their websites. Several months ago, the Ministry of Health, they release and they produce this kind of visualization information about subnational testing data, thanks to the government after several advocacy, after several pressure in the media to pursue the government to open the testing data. I think Irma from Lapor COVID would like to share this experience as well. But the problem with the data structure here is the short period of historical data, I think several months back, and there's a limited data extraction facility. If you would like to run the further analysis, you need to go to contact the ministry directly. This is, you can see the table here. This is the first high expectation of the daily testing data. If we repeatedly mentioned to the government, also to the local, to the central government to release this kind of data. This is the number of the daily testing. As you can see from the left side, the columns, the date. This is the date of the sample taken. It also shows the number of tested people, the number of positive and positivity rate. You see from the mid-up table, it shows the current situation, but the below table shows where the Delta variant rampage in Indonesia. So you see that the proportion of positivity rate is about 2% in this month, but 30, 40% or 50% positivity rate during the in July this year. So this is the expectation of the daily testing that we recommended to government to be transparent. It shows the real situation. There are another example of the daily testing visualization in West Java and East Java. You can see, you feel the difference, right? You feel that it's not easy to understand. It's difficult to extract. They are not allowed to. They don't give any access to extract the data. The website. West Java and East Java is, I would say that the top 5 provinces contribute to the COVID in the countries. So you will see the difference between the willingness to share and data sharing of the daily testing in these areas. And then we also at that time interested to see then how the COVID data presented. In the mid-year 2020, I think dozens of volunteers in Lapor COVID visited all websites, and then they found that 447 districts had a website, whether specific or use the existing government website for the COVID data dissemination to the public. And we assess the 5 variables of criteria. You can see here the availability of local contact or data source, regular update, whether they have whether they updated the data regularly, and the ability of the website to provide us to extract the data, whether in the Excel or TSV format, historical data, or essential indicator. And we find it, the problem with the system that there is no most of the majority of them, they don't have the functional ability to allow us to extract the data. And they also don't have the ability to historical data analysis for the trend analysis. And we look at the document and then how they present the data nationally and then subnationals. There is no standard requirement at the time for data dissemination. And also we see that most of the WISAT, the lessons of crisis, and I would say that less data presented there, and also less data sharing practice. And when we examine the essential data indicator displayed in the website, we see that various and inconsistent presentation of the data COVID display in the public dissemination. This is one, the internet story. Pa Terry is very interested in the birth and the birth analysis. We are interested in death countings, actually. And we compare and how the provincial, we compare the discrepancy between the national and the province about the death toll. As you can see here from, let's say for example, in Central Java, the provincial websites reported about 26,000 deaths, but the Ministry of Health admitted 16,000. What are the gaps? Why we find the gaps here? When we asked the government, they mentioned that they didn't include the probable death, but actually in Central Java, they also counted the confirmed case. But I think Irma will be happy to elaborate it more. But this is the problem with the data accuracy and data quality, especially in the death counting. So we also did some project now. We are still ongoing, tracking the all-cause mortality in the 12 cities across Indonesia to look at the excess mortality as an alternative indicator of death counting. This is one of our, we call it, results publications. The most updated one will be published, I think, in several weeks to come. This is only for in 2020. You can see that, especially in Jakarta, we saw that 61% of excess burials in 2020. Where did the data come from? The data come from the burial. The data come from the health facilities, death registration, and also from the civil death registration. But the last two actually fails to detect the early pandemic because most of them.
Sorry, less than 2 minutes, ya Pak Iqbal.
Okay, yeah, most of them are reluctant to report the civil death registration as well. And one thing is important also. There is no the data about the health worker burden, especially health mortality. Until now, we don't have any information about how many health workers have been infected. And this is one of the lab for COVID and the collaboration to release the Pusara Digital or Digital Library in September 6th. Actually, we compile the information to calculate, to quantify how many health workers lost during the pandemic. And to the last 13 September, we recorded over 2,000 of health workers died during the pandemic. And you see that in July 21, this is the rising trend of the health worker death. And also we recorded the fatalities during the self-isolation or self-facility because at the time there is overcapacity of hospital usage in Jakarta and in several areas in Java and Bali. What the conclusion here? So there is no real-time COVID data 19, virus quality within the system, low quality in that counting, and low to moderate quality in the testing and epidemiological investigation data. And I wanted to mention that obtaining and utilizing the COVID data actually demands good intention, political will, leadership, and also the actual need, scientific-driven policy. But now is the time for Indonesia to move forward in the field of health informatics. Urgent to update the national master of population data, reforming the passive death counting to active counting in the civil death registration system by using the technology. And also they need to be less bureaucratic data sharing process, but ensuring the intellectual properties and mutual benefit. I think I will say thank you to my colleagues in Eggman, Oxford, and also from the Oxford Clinical Research Project in Vietnam to provide funding for this one. And also thank you for 15 to 20 journalists who involved as a fellow in Tremor Project. Thank you, the Love for COVID, and thank you for the all volunteer in Love for COVID. Thank you so much.
Thank you very much. Can you hear me okay?
Yeah.
Sorry, my computer just crashed, so I have to quickly switch into my iPad and I'm unable to use my Zoom background. So it's now Q&A, and please, I would invite Pak Terry to come back to the spotlight. Great, we've got some questions already, and the first question is not a live question. It's a question from Pak Inyoman Sutarsa addressed to both Pak Terry and Pak Iqbal. I'm going to read it out. Thank you for the excellent presentations. My question is both for you. Statistics are very powerful. Can you both please comment on the politics of statistics or health data in Indonesia and how these could impact the allocation of health resources? So I'm going to go, I think Lily might like to ask the question live, but before going to Lily Pramawanti, I would ask perhaps Pak Terry first to answer Sutar's question, followed by Iqbal. Thank you.
Asking me about the politics of statistics is a dangerous question. What I would say is that it is very important right now for Indonesia to step up to questions of professionalism in data. The professional associations, from my observation from far away, have not been as active as they might have been. And in this, I would include the Jaringan Epidemiologi Nasional and also the various medical professional associations. I think that BPS has been hamstrung or has been prevented from doing a better job because of the huge budget cuts. It is justifiable to move money from statistics to treatment in the middle of a pandemic, but it is questionable whether those movements should be so large as to undermine the actual treatments, because the data that have been used to guide the programs have been weakened. So I would just say that. Thank you.
Okay, berikutnya silakan Pak Iqbal. Do you have a response to that question?
Terima kasih, Pak Nyoman. So the politics of data, especially in pandemic, I think is challenging because the COVID-19 data is related to the image of the leadership. Don't forget that in December 2020, there was the local elections. So we observed that 2 months before the pandemic, that the number of testing was decreasing, and the number of positive cases also were concealed at the time. Because why? The central government wanted to have local elections conducted in December 2020. Our COVID was an active role with the other civil society to remind the government to be careful to run the elections, because at the time with the other experts and scholars in Indonesia, we estimated the 100 of the cases will be generated during the local election. You need to remember that the preparation of the election is 3 or 4 months before December. So the COVID-19 actually is heavily affected by the image. That's what I say. And technically, I don't know about the allocation data, budget allocation to the data especially, but from our observation of the openness and the transparency in the local area, especially in Jakarta and also in West Java and other areas, we don't, especially in other areas, especially under areas probably in Eastern Indonesia, we don't see any much higher allocation for the data structures improvement and the others. So that's my impression. So I don't know whether probably Irma would like to step in, please.
Iya, silahkan Ibu Irma, the floor is yours. I mean, the screen is yours. Ada Ibu Irma?
Tadi ada kayaknya.
All right. Thank you very much. Sorry, I cannot put my screen on. Hope it's fine. So I think, yeah, it's a good question. Thank you so much. And thank you so much, Pak Iqbal, for the explanation. I just want to add, I would like to use the term of the statistical data on COVID-19 in Indonesia right now is actually depends on the political will. I hate to say the political will term, but as mentioned by Pak Terry and also Pak Iqbal, is actually because the government has the infrastructures, the government hold the powers of, the human resources, data and statisticians expert, along the way from the national through the very smallest level of kecamatan or puskesmas. I think I would imagine it's not too hard if the top level could, like, for example, lead the data collections, data gathering using its internal bureaucracy, and asking all levels of authorities to collect and present essential epidemiological statistic data on COVID-19 openly or transparently to the public. So I think that is the key components that unfortunately we don't currently have right now. So it's speaking about statistical data, is I think we are facing a very big challenge to push the governments to open, to be more transparent and to be more accountable in order to present the real data from the ground. I think that's from me. Thank you so much.
Thank you so much. Makasih, Ibu Irma. So next we have another round of live questions from Hatip Basri and Lily Pramawati. Mbak Lily, are you ready to ask your question?
Yes, I'm ready. Can you hear
Silakan.
me?
Yeah.
Yeah, thank you, Pak Terry and then Pak Iqbal for the presentation. I just wonder, in order to understand, health profile of Indonesia, actually we not only need to rely on survey data. It will be great if we have a nice record on what cause of death of mortality, especially among adults, which is right now we don't have very much information about that. I just wonder whether there is any information about what's government plans, or maybe is there any work that now is ongoing across ministry to strengthen the vital mortality data, especially among adults. So hopefully by this data, we can further have more understanding about what's the situation of Indonesia, especially the adult health at the moment, and then how it give us a future information about how gonna be Indonesian health in the future, especially as we will as we experience growing aging population as well. Yeah, that's all I think my questions. Thank you.
Terima kasih. Thanks, Mbak Lily. So next, Pak Hatip, are you ready?
Yes, can you hear me?
Yes, we can hear you. Yes.
Okay. Congratulations for the update. This is a layman question, forgive my ignorance. I believe that this data quality problem is not unique only for Indonesia. Yeah, maybe some other developing countries or emerging economies are also facing the similar situation. We do understand we have a problem due to the, as Terry mentioned, about the decentralization, the limitation of the budget. My question is, perhaps can you share with us, both of you, Pak Terry and Pak Iqbal, is there any sort of like country that we can benchmark with our given situation as a close comparator? And then can we learn something from their experience, how to handle this issue? Because I do believe that this is not going to be a sort of, there is no shortcut for this. Yeah, but in the short time for the very pragmatic solution, is there anything that we can learn from other country experience to solve this problem? Thank you.
Ya, silahkan Pak Terry, and then Iqbal.
Thank you very much for that question, because I think we could look at benchmarking in two dimensions. One is other countries, and we do know that across Asia, there are many countries that have strengths in the collection of data, for instance, on cause of death, that are much greater than the Indonesian strengths. I would put out there Vietnam and China as being two countries where we can learn a lot. But the other dimension is history. The data on cause of death in the 1930s, collected in many kabupaten across Central Java, are much better than the data that we collect today. So we can look to Indonesia as the example to lead Indonesia. And I think that that would give us a lot of information that every public health and medical person should be studying as part of their university education. The issue of budgets, though, I think that the question of how do you manage budgets for data is a very difficult one, because if I look across the different government departments, one of the things I see is that at the director general level in ministries, there's often a lot of competition among directors general to collect data, and they are often collecting data that is inconsistent one section of the ministry with another. The One Data initiative, as Pak Iqbal set out in one of his slides, is an excellent set of principles. The problem is the implementation. And I don't know where the strength will come from to implement a much better approach across the national institutions and the local institutions, right down to the village level. Thank you.
Ya, silahkan Pak Iqbal, if you could respond briefly to that. Anything to add?
Yeah. The vital death registration, I will answer Bu Lily first. Yeah. The vital death registration has been tested by Litbangkes, National Health Research and Development, for I think 2 or 3 years, and it's ended in 2018 at the 100 districts. Afterward, they had no allocation to expand the vital death registration to other provinces. So that's one thing. But we also need to understand about the data flow of the vital death or the death counting here, Pak Khatib Bisri. Let's say, for example, according to the law of administration of populations, Undang-Undang Administrasi Kependudukan, number 20 in year 2018, if I'm not mistaken, the system of the death counting is a passive. If you have a family members deceased, dead, and it is required for the Ketua RT to report it, the family, to report the event to the local civil death registration. It means that if the family or the Ketua RT did not report it to the civil death registration, we will miss the data. There are some studies by the Litbangkes show that actually the passive counting system missed 20 to 60% of the actual mortality. So So if we receive the report of death, the death counting, whether in BPS or in other ministry, we need to think about, this will be the under count is 20% to 60%, because the system is passive. That's why in my presentation I learned from the COVID-19 pandemic, the system must be changed to the active. The civil in the Ministry of Internal Affairs, as Pak Terry mentioned, there is a directorate specific for register birth and death as well, and any other events. Birth and death is a very important event in the population health system. And this director of general should be more active to collect the data from the ketua-ketua RT, because the ketua RT, according to our observation and in several areas in Java, they have a very good system to record the number of their members who died during the pandemic. But because the system is a passive, of course we will miss the data. So the investment to be change the system, change the regulation first to be the active. I don't know whether the Australia or the other countries they have a passive and active system, but that will see the flow in the current death registration in Indonesia. So that's my comment.
Thank you, Pak. We don't have Pak RT or Ibu RT where I live here. So, so the organizer has given me the permission to go 2 minutes over time. And what I'll do is I'm going to ask Ibu Ann Booth to ask her question. She has a specific question to Pak Terry. And for the other panelists, if you don't mind, there are lots of questions that you could also type the answer if you like later after this session for the other questions listed in the Q&A. So silahkan Ibu Ann, ada last question for Pak Terry.
Can you hear me?
Yes, we can hear you nice and clear.
Fine. Well, thank you very much for these very, very interesting presentations. I'd like to ask Pak Terry about the role of the BKKBN in the stunting program. Why were they given responsibility? And to what extent is it interfering with what one might think of their traditional role, which of course is providing family planning facilities? You may know there's a program here in London, Action Against Stunting, which has been presenting quite a lot of data on Indonesia. But I was a little surprised at their assertion that the BKKBN has apparently now a primary role in this. And I wondered if you'd explain why.
Thank you very much, Bu Ann Booth. So Pak Terry, 30 detik. Terima kasih.
BKKBN and the Ministry of Health have been in competition for the family planning activities of the country for almost 50 years. And the BKKBN over the years has always moved into other areas to expand their mission and vision. If you go to their website, they have a lot of information as to why they feel themselves to be strong on dealing with stunting. And it has to do with the original activities that they carried out in the post-Yandu era, where the BKKBN officials with health officials would work to improve nutrition. I am totally skeptical of any value coming out of this.
Wah, terima kasih. Perfect 30 seconds. I'm afraid we have run out of time. I do see some questions that haven't been answered from Pak Wahyu Susilo, from Lila, and from Syafiq Asegaf and Riana. So maybe Pak Iqbal or Pak Terry, you're welcome to answer, type your answer. I'm going to now pass over to Associate Professor Sharon Graham Davis, who will be chairing the next session. Terima kasih semuanya.
Terima kasih Aryan. Now on sound. Selamat siang, selamat sore teman-teman. Mudah-mudahan kita semua tetap berada dalam keadaan yang sehat, dan dengan senang hati saya akan memimpin sesi ini. Nama saya Shannon Davis dan saya Direktur Pusat The Herb Feed Indonesian Engagement Centre di sini di Melbourne, Australia. Di panel ini, panel 4, adalah 2 paper dan 4 presenter. And the panel is called Towards Equitable Healthcare. And the first of those papers is entitled Impact of COVID-19 on Maternal and Child Health Programs, a case study for strengthening the health system. And this will be presented by Tiara Matias and Yodi Mahendrahata at Universitas Gadjah Mada. Our second paper is The Right to Health and the Politics of Health Policy in Post-New Order Indonesia. And this will be presented to us by Andrew Rossa at the University of Melbourne and Lucky Gianni at Universitas Pembangunan Nasional Veteran Jakarta. So I'll invite in a moment both of those speakers to speak for 20 minutes and really encourage them to keep to that time, because we've just seen now that people have a lot of questions. This will give us 20 minutes for questions. Please type your questions into the chat box or raise your hand and we'll come to you at the end. And for everybody, presenters and those asking questions, I really encourage you to try and not speak too fast, because we have signing and translation, and it really makes their job much easier if we all slow down in our presentation. So without further ado, I will turn over to our first presenters. Terima kasih.
Thank you, Sharon. Can everyone hear my voice okay? Sorry?
Yeah, we can hear you.
Okay, cool. So good day, everyone, and thank you so much for joining the session. And it's been a pleasure to be able to contribute in such a forum. Pak Yodi and I are presenting the impact of COVID-19 on maternal and child health programs, which we would hope to serve as a case study for further discussion on health system strengthening in Indonesia. So some background on the maternal and child health burden and the COVID-19, which have been discussed as well in previous days. And also we would like to see what's going on with the MCH services during the COVID-19 pandemic by using a time series data. And then to move forward with the health system responses and challenges, and also what we have been done and what's the existing challenges even before COVID and exacerbated after COVID, and how to deal with that. So a bit about the maternal and child health burden in Indonesia. We know that with 177 maternal mortality ratio per 1,000 live births, Indonesia is not doing good in terms of MCH. Comparable with other Southeast Asian countries, we are one of the highest maternal and child health burden, even with the dearth of data collection in terms of mortality and morbidity as well. And with the neonatal, infant, and under 5 mortality rates, we're not doing well as well. We have attained some of the MDG back in 2015, but a lot of the targets aren't achieved, and there has been some pessimistic view on whether we would achieve SDG, particularly in terms of inequality and inequity in healthcare outcomes. And then also more acutely the prevalence of stunting. So with 31.8%, it means like 1 in 3 of our under 5 children are actually short for age. And this is comparably higher across the region, and also consistently always higher compared to the average of other low and middle income countries in the last 10 years. These are all issues that are already exist before COVID-19 and needs to be addressed through health system strengthening, but also exacerbated during the COVID-19 pandemic. So the burden of COVID-19, a lot of the other presenters have wonderfully viewed data on COVID-19, but I just wanted to highlight that even though Java and Bali have been burdened so high with the COVID-19 pandemic, but also areas such as Papua, NTT, Maluku, Kalimantan, are also facing a lot of problems, especially with the inequity in terms of supply side distribution. And for example, NTT doesn't even have PCR in all of their islands, only Kupang has, and which evidently have been detrimental in managing COVID-19. And also in terms of vaccination rates, we know that in Jakarta, for example, where I live currently, we have achieved 90% or even 100%, depending on the data that you use in terms of coverage rate for the second vaccine. And some people have even received the third booster dose. But areas such as NTT have 11%, Papua have 11%, even Sumatra have a mere 20%. And these are all evidence of the inequality in terms of infrastructure, but also the prioritization of in our health planning and budgeting in Indonesia. So back to the MCH. During COVID-19, we've seen a lot of news about how pregnant women who are positive have been turned down to deliver at the hospital because hospital, especially in the early period of COVID-19, didn't really know how to deal with COVID positive pregnant women and what are the guidelines or kind of PPE they need and all that. So a lot of them ended up not having access to the necessary health services. And also, if we talk about family planning as well, we've seen higher total fertility rate during the pandemic, not just in Indonesia, but also in other countries across the world, because one of the reasons would be limited access to contraceptive methods. A lot of the methods are actually acquired from puskesmas, and puskesmas have often been closed down in several areas in Indonesia. And in terms of child health, the closure of posyandu, especially in 2020, means routine health services such as immunization, weight management or weight monitoring for under 5 have been also depleted during those times. And since posyandu and puskesmas are our primary service delivery points for MCH, the closure of such facilities, or at least the limitation of its working hour, have of course means negative impact on the maternal and child health services. And this has been documented even back in 2020 when UGM did an electronic monitoring and evaluation study focusing on 260 districts with very high number of stunting and have been deemed as the priority district areas in terms of stunting prevention and alleviation programs. So the 260 districts claim that out of the 260 districts, 86% claim that they have had severe disruptions on child health services during November 2020 because of COVID. These services include growth monitoring, which is acutely necessary to see whether the kid or the stunted children have catch up to their development, severe acute malnutrition management, food supplementation, and also vitamin A supplementation. So even in 2020, a lot of the posyandu puskesmas have been closed down, or at least have a limited service hour. And now we wanted to see the overall condition of the MCH services during COVID-19 pandemic and see what its impact on other services included in the MCH routine care. So a bit about the data. And the MCH, the data that we use is the routine health data, which are reported from the district level to the Ministry of Health using an application called DHIS2. The data set included several key maternal and child health indicators, including pre-pregnancy, pregnancy, delivery, and also early child health services, and including immunization. However, it should be noted that with issues with any routine health data in low and middle income country are also applicable to our data, means that some of the data might be missing, inconsistency, incompleteness in reporting, but we did some cleaning up of the data and also smooth it down using an exponential smoothing to make the data more representable and see if it could capture a bit better what happened throughout these pandemic. And as for the COVID-19 data, we procure data from our World in Data, which is essentially the same data that is issued by the Ministry of Health. And also we focus on the daily cases or daily confirmed cases of COVID-19. So first, we wanted to look at antenatal care and facility delivery. So antenatal care is all the visits you do during the pregnancy, which could be divided into two types of visits. It's the first antenatal visit and at least 4. The at least 4 one is the one that we use in Indonesia as a guideline to proxy a quality care ANC. So throughout 2019, as seen in the draft, from January to end of 2019 and February 2020, it's kind of okay in terms of stabilizes over time and with some fluctuations in terms of the data reporting. And also these are all absolute numbers of data. And then, however, in March 2020, when we had the first few cases of COVID-19 in Indonesia, we see some dip, especially in the first antenatal care. And then it kind of stabilizes over time again, even though the trend is not as high as the one before COVID-19 pandemic. And unfortunately, following the Pilkada, the holiday at the end of last year, and also a high mobilization, we see a spike in terms of COVID-19 cases in December, January, and February. And this is where the dip in the terms of coverage of the antenatal care and facility delivery has never bounced back. And during the Delta wave variant, the coverage of these services have plummeted down even further. Unfortunately, we don't have data for August and September, so it would be interesting as well to see whether at least some areas have bounced back from the decrease in the coverage rate. So for postnatal and neonatal checks, which is occurred after the delivery, similar trend were observed as well. Slight dip in March and then stabilizes over time, but also didn't bounce back after the first huge wave and the second wave of the Delta variant in February and June 2021. And unfortunately, for child health services, it's a bit more impacted by it seems to be a bit more impacted by the COVID-19 pandemic, which is mainly, we suspect that child health services in nature are more intensive and have to be delivered more regularly in terms of monthly immunization or at least 3 monthly immunization, monthly child growth monitoring and supplementation, for example. And with the closure of Posyandu and Puskesmas, these services are essentially not available anymore to the population. And we also observed limited outreach program in terms of, for example, home visits in many of the areas which have been negatively impacted by the COVID-19. So that doesn't help as well to recover the service coverage. And social mobility restriction have been also documented to have detrimental impact on the likelihood of people for health-seeking behavior. But even before COVID, we have to acknowledge existing health systems challenges, human resources and medical health supply inequality in terms of socioeconomic and geographical distribution, our issue with data, as I mentioned before, and also because the decentralized health system means like we highly expect that every district has the capacity to analyze their data, do a data-driven or evidence-based planning and budgeting. But we know out of the 514 districts in Indonesia, not a lot are actually capable and have the capacity to always do that. And even with COVID, it became even more difficult for them. And health finance and expenditure on health, as Pak Laksono mentioned the first day, we have one of the lowest health expenditure on health. We spend in 2018 $112 per capita for health expenses. This is 1/4 of Malaysia, where they spend $400, and even Thailand is $276, and even Philippines, our neighbor, which are more comparable, spends almost $140 per capita per year on the same year. So with JKN, yes, we might have universal health coverage, but coverage of what? Coverage of the card or coverage of a quality maternal and child health care? That's a different story, and I think needs further discussion and strengthening. And also for the skilled birth attendance coverage, even before COVID, again, a lot of it are concentrated in already developed areas, Sumatra, Java, Bali, but people living in Maluku and women delivering in Maluku, only less than 50% of them were actually assisted by either doctor or midwife or OBGYN. And availability of health workforce for pregnancy and delivery. In this graph, it's the number of doctor and midwife who can assist for delivery. We see a lot of them are actually concentrated in Java and Java Bali area, of course. But also then if we do the ratio to 1,000 population, it seems even West Papua here in the left far hand side is not doing that bad. And this is a problem because in a lot of our planning and budgeting relies heavily on whether you have met the ratio. So if a district have met the ratio of certain, for 2.5, for example, doctors per 1,000 population, it would be difficult for them to further mobilize more health workers. But we know this is only because the population is so small compared to Java Bali area, and the use of ratio would be detrimental to really portray the availability of health workforce in those areas. And if we see using a geographical area coverage by using a ratio to 50 kilometers square, for example, in West Papua, 35 staff have to cover 5,000 kilometers. In Jakarta, you have 1,400 staff to cover 450 kilometers only. So this is the portrayal of our existing problems even before COVID. So the ones exacerbated by COVID is the human resource and for health and supply constraints, of course, with the high number of patients accessing the healthcare, and also they're confused about navigating the new healthcare flow. It's during the first few months of the pandemic, it wasn't really sure when the puskesmas is open, in what day, and which door you have to come in for delivery. If you have COVID, what do you do? And who will be taking care of you if your child is positive COVID, they need immunization and stuff like that. So these are all the existing health system issues that we need to address first before we talk about managing COVID, really. So moving forward, we have all the guidelines during the pandemic, and some really good initiatives have been rolled out, including telehealth and home visits. Some of the districts that were surveyed last year had really good home visits. They utilized a WhatsApp group, for example, for women and children, at least for antenatal care, counseling. They can do that remotely. However, again, to strengthen the health system for MCH, and this is my last slide, just some aspects of the health system components that we need to focus on. The first is, again, equitable human resources and supply, making sure that quality human resources and supply and infrastructure are in place first before we can talk about quality and care and universal health coverage. Service delivery and innovation. So things like telehealth and alternative service delivery points should be explored a bit more. Maybe home care and telehealth. Can we include home care and telehealth as part of the JKN coverage, for example? We haven't been able to do that, and that is why people with money essentially can access telehealth, but not people who are actually have limited access to healthcare. If we can cover this under JKN, maybe for outpatient services including outside of MCH, it would increase at least the coverage of services for the population. And patient flow evaluation is also needed, not only for MCH, but also inpatient, outpatient, and the third is the private sector engagement. Our health system comprised of 70% health service provider. Our hospital beds and hospital are 70% private, actually, but we haven't really tapped into this capital. We have tapped them for testing for COVID, but and some of the inpatient services for COVID. But why don't we tap also the private sector for procuring other services, including MCH, particularly during the closure of Puskesmas and Posyandu, for example. And finally, removing financial barriers. So it's not just ensuring sufficient funding for quality of care, but also removing financial barriers. For example, in the COVID era, a lot of the women are tested for COVID, but they do need to test for themselves, and it doesn't come cheap, and that has been detrimental to the health service utilization as well. And again, telehealth and coverage for home visits should also be financed either through JKN or other fund channeling. And these are all the things that we thought needs to be in place first before we talk about our resilient health system. And that concludes our presentation, and thank you so much for the time, and look forward to discussing with you all. Thank you. Over to you, Sharon.
Thank you. I can't turn my camera on. It's there we go, thank you. Great paper, Tiara. Thank you so much for that. And I'm sure there will be a lot of questions. So please start typing them in. We never get through them all. So if you get your question in quick, there's a bigger chance that we'll get to your question. And very well done with the timekeeping. Thank you, Lydia. It's got us on there. Even I'm on a time for presenting the next speaker, so I'll get to it. So we're turning now to Andrew and Lucky. I can see you both here, so the floor is yours.
Okay, here I am. Thanks, Sharon. Give me a moment. I'll just get my slides on the screen. So look, there they are. Are they visible to everyone?
Yes.
All right, good. Okay, yeah, so look, as Sharon announced earlier, the title of our paper is The Right to Health and the Politics of Health Policy Reform in Post-New Order Indonesia. And yes, it's a paper that I've co-written with Luki, who's here with us today to help me out with the Q&A session, but I'll do the presentation. Before I turn to the paper proper, I thought it might be helpful for us to say a couple of preliminary things to explain why we've written the paper that we have. The first of those preliminary comments is that to the extent we know something about the politics of health policy in Indonesia, it's mainly because scholars have written about the politics of specific health policies, and especially health insurance. We've seen over the past few years quite a few studies tell us the story about how Indonesia introduced programs like Askeskin and Jamkesmas, and eventually established the national health insurance scheme. What the literature lacks, I think, is an overarching account of the politics of health policy in Indonesia since the fall of the New Order. And in particular, it lacks something equivalent to a chapter that Joan Nelson contributed to a book called Crucial Needs, Weak Incentives, which looks at the politics of social sector reform in Latin America. In that paper, she looks at the sort of overarching story of politics, of the politics of health policy in Latin America, but importantly, disaggregates the health policy reform agenda into a number of discrete components and traces the way in which the political dynamics that have shaped health policy have played out in relation to those specific issue areas. And the point she makes is that different issue areas have been characterised by different politics that have yielded, in turn, different reform outcomes. So we're aiming to try and present an analysis along those sorts of lines. As I note on the slide, I think our paper is a preliminary effort in that respect. As I'll explain in a moment, the analysis is built around 3 particular policy case studies. Ideally, we'd have a few more than that, and I think that indicates there's a sort of broader program of work here for us to sort of carry out in the future, to bring in other case studies and present a richer picture. The second preliminary comment is that in writing a paper about the politics of health policy reform, it's important to define the nature of the reform agenda. In separate work that I've done looking at the politics of education policy in Indonesia, I've highlighted the influence of neoliberalism in shaping the policy reform agenda in that particular sector. Neoliberalism has had a very powerful influence on education policy in Indonesia since the fall of the New Order, and so it's made sense to shine a light on neoliberalism in that particular set of work. Neoliberalism has just been a less powerful influence in the health sector. A more progressive, rights-based sort of agenda has really characterised or defined the nature of the reform agenda in Indonesia. There have been neoliberal components, but by and large, they were killed off fairly early on in the piece. So we shine a light on the right to health in the paper. All right, so let me turn to the paper proper now. We begin the paper by noting that since the fall of Suharto's New Order, Indonesia's political elite has made significant changes to Indonesian law, affording greater recognition to the right to health. And one can sort of see that most readily in the changes made to the Constitution, where a right to health services was introduced, a right to a good and healthy environment was introduced, a right to social security, which is a very sort of closely related right to the right to health. But it's also, that change has also been incorporated into lower level laws and regulations, including most importantly the 2009 health law. These legal commitments have been accompanied by health policies and programs that have sought to promote the right to health in various ways, including the efforts that Indonesia has made to introduce health insurance programs for the poor and ultimately to build a national health insurance scheme. Indeed, when the UN Special Rapporteur on the right to health visited Indonesia in 2017, his subsequent report drew attention to Indonesia's progress in promoting a policy framework that was aimed at fulfilling the right to health, and in particular via the steps that Indonesia had made in trying to realise universal health coverage. Health expenditure, the increases in health expenditure that have occurred since the 2009 health law might also be mentioned as a policy setting that is consistent with a more rights-based approach to health policy. On the other hand, though, you've had a lack of progress or stymied progress vis-a-vis the right to health in a range of other sort of health policy areas, such as the ones that I mentioned on the slide there. I won't go through them in the interest of time, but the broad point is that there has been an uneven process of reform in terms of the right to health since the fall of the New Order. At the same time that there's been a broad shift towards a more rights-oriented approach. Now, the purpose of the paper is to try and shed some light on the reasons for this pattern of reform and the likely future trajectory of health policy in Indonesia by examining the political dynamics that have shaped health policy in the post-New Order Indonesia. So we've resisted the temptation to just focus on the COVID-19 period, although we do in the paper consider the implications of COVID-19 for the nature of health policy in Indonesia. The paper is organised into the sections that I identified there under the heading structure. The first of those sections identifies the main actors, interests and agendas that have been at work in relation to health policy. I won't go into detail on the nature of those actors, interests and agendas, other than to note that broadly we distinguish between sort of predatory elites, technocratic elites, progressive elements, populist elites and popular forces. They're the key actors whose interests and agendas and activities we explore in the paper. We then have a section that looks broadly at the shift towards a more rights-oriented approach to health policy in the post-New Order period, and then turn to the three focus case studies, which are health insurance, tobacco control, and health security. We then have a conclusion that looks at the implications of COVID-19 for the politics of health policy and the trajectory of health policy reform. The paper makes three main arguments, and I'll focus mainly in this presentation on the second argument. But briefly, the first one is that the greater overall priority given to the right to health in Indonesian law and policy has reflected the broad realignment of power relations that accompanied the fall of the new order. This realignment, which entailed a shift in power away from predatory elites nurtured under the new order towards technocratic, progressive, populist and popular elements, created a political context more conducive to rights-based health policy. At the same time, however, the fact that predatory elites were able to maintain and have recently reasserted their political dominance has imposed significant constraints on the extent of such change. And so the result has been an uneven process of rights-oriented reform in which the fate of rights-oriented initiatives has depended on whether they have threatened the interests of predatory elites and attracted support from popular and populist elements. Broadly, we suggest reform has proceeded furthest where reform initiatives have sought to enhance access to health services and least where they have sought to address the underlying preconditions of health, reflecting the fact that the former type of reform has created new stakeholders, altering electoral and mobilisational politics, whereas the latter has not. Now, on this slide, I've got a table that attempts to sort of capture our argument in relation to the three focus case studies. The first line corresponds to the first row, that is, corresponds to the health insurance case. And broadly, this is our successful case in terms of the character of the reform. So we say on the slide there that the reform outcome has been extensive. It's of our three focus areas, it's the area in which most has been done in terms of creating a sort of rights-based policy framework. The politics that led to that outcome is one whereby the reform disrupted predatory interests. Health insurance reform was a reform that entailed cuts, for instance, to the government's fuel subsidies, which benefited the business sector and the middle class. It entailed the imposition of new costs, new taxes, new charges on the business sector, particularly with the establishment of the National Health Insurance Scheme. And there was, not surprisingly, pushback against these schemes, and in particular the establishment of the National Health Insurance Scheme from the business sector and aligned elements within the state. But that resistance to change was offset by the fact that reform in this area was driven to a certain extent by popular and populist elements. So health insurance reform was something that political elites, initially at the local level and then subsequently the national level, latched onto because they thought it would help them win some votes in elections. As many people would know, there were huge demonstrations in 2010, 2011 on the part of sections of the trade union movement, supported by elements within the NGO movement, to try and force through or trying to put pressure on the government to enact crucial implementing regulations or implementing legislation to make the JKN a reality. The second row in the table corresponds to the tobacco control case, and this is, I guess, if you like, the least successful of our cases in terms of the establishment of a rights-oriented policy framework. Indonesia has, since the end of the new order, introduced some changes, some important changes to tobacco control regulation that are consistent with a more rights-oriented sort of approach. For instance, it's introduced pictorial warnings on cigarette packets. The written warning that goes on cigarette packets has become more strongly worded, but otherwise not a great deal of change has materialised. Indonesia has failed to sign up to the Framework Convention on Tobacco Control. Cigarette advertising is still incredibly widespread. Cigarettes are very easily purchased, including by minors and poor people and so on. So there's been very little constraint in terms of the marketing or retail of tobacco products. And we argue in the paper that this kind of comes from a different sort of politics. There's the tobacco control reform has disrupted or challenged predatory interests in much the same way as health insurance, but you haven't had the offsetting effects of support from popular or populist elements. By and large, tobacco control reform has not been something that political elites have taken to elections in the hope of winning votes, nor has there been large-scale mobilisation on the part of popular forces in support of tobacco control initiatives. Indeed, if anything, mobilisation by popular forces has operated on the other side to the extent that the cigarette companies have successfully managed to mobilise support from tobacco farmers and tobacco workers to protest the introduction of tobacco control reforms. The final case study we look at we call health security. This focuses on two things. The first is Indonesia's compliance with the international health regulations, and the second is to do with the way in which Indonesia has actually sought to harness the capacities that it's developed in relation to emerging infectious diseases to combat particular outbreaks. We have that down in the third row of the table, corresponding to a sort of political situation where the reform did not disrupt predatory interests, mainly because the moves Indonesia has made to comply with the international health regulations have not, by and large, entailed imposing extra costs on powerful business interests or political elites or anything like that. Nor has it entailed withdrawing privileges or benefits that they happen to have. And Indonesia has, one of the interesting things I discovered in researching this particular case study is that prior to COVID-19, Indonesia was, I think widely seen as something of a success story in terms of the building of capacities and the building of an institutional framework for combating emerging infectious diseases. And indeed, to some extent, it was taking a leading role globally in the development of frameworks for combating emerging infectious diseases. The thing is that when it's come to actually combating specific disease outbreaks, whether it's COVID-19 or avian influenza, Indonesia's often balked at putting in place the sort of measures that are required to actually successfully combat the disease outbreak. So, we argue that this is a sort of an intermediary case in terms of the outcome. While we've got it there in the third row of the table, it overlaps in part actually with the space occupied by the tobacco control case study. All right, this is my last slide. The third sort of argument put forward in the paper really looks forward and takes into account the COVID-19 situation and asks, well, what does the future look like? And we argue, we make two main points. That the first is that the uneven trajectory of reform is likely to continue into the foreseeable future in the absence of any fundamental realignment in underlying power relations. And it remains to be seen whether COVID-19 will produce such a realignment. I mean, at the moment, there's not a whole lot of evidence that is going on, but it still remains, it's too early to tell, it remains an open question. The second point is that even if COVID-19 does not shift the overall alignment of power relations in Indonesia, it is possible that it will alter the political dynamics surrounding specific areas of health policy, and clearly the most likely area for this to happen is health security. And in the paper, we look very briefly at some things that are going on that are indicative, for instance, of the possibility or the potential for that sort of populist dynamic that I referred to earlier to trigger measures that may serve to enhance Indonesia's health security policies. All right, I better leave it there because I suspect I'm a bit over time.
Terima kasih, Mbak Andrew. You perfectly timed. You had a whole another minute and a half, but that's that's awesome. We can use that for questions, and we already have quite a few coming in. So I'll jump to the first one that I received, and it came through to me as a direct message. So I'll just read it out. It's for Mbak Tiara. And the question is about the declining trend of maternal and child health services once COVID had started. And the question is, Tiara, whether you can confirm if there's a difference between, say, Java and Bali on one side and outside Java and Bali, considering that there's differences in the case numbers of COVID-19.
Right. Thank you for the question. Yes, we did not. Oh, sorry. We did not show the graph, but it's absolutely right. The majority of decline was observed for Java and Bali because those were where most of the cases happened, and also where many women and children live. But the effects on the other areas was only observed later in the year of 2020, because I think the pickup of the pandemic in those areas came in a bit more later, and also the number of case increase were not as rapid as the ones in Java and Bali, especially in the first few months of the pandemic. However, and also in the additional analysis that we did, it was harder for areas like Kalimantan and Sulawesi to bounce back after the decline in their coverage rate following first few months of the pandemic in Indonesia. Over to you, Sharon.
Great, thank you. Our next question is from Ed Aspinall, and he would like to ask it directly. So I think the host will unmute him. Ed, if you can ask your question.
Thank you, Sharon. So my question is for Andrew and Luki. So your analysis would seem to suggest, like from this comparison of health insurance and tobacco control, that popular or populist demand or pressure can counterbalance predatory interests. You know, that seems to be the point of, or the conclusion we can draw from that comparison. So I guess my question would be, what do you see as the structural or other obstacles to greater expression or articulation of those demands for improved healthcare service? Why don't we see, in particular, more sort of, a greater influence of a just much more basic sort of demand for improved healthcare services overall throughout the whole system? What are the obstacles you see operating there? If there is that potential, why don't we see more demand for more healthcare, better healthcare services? Thank you.
Luki, do you want to have first go at that?
Yes, Andrew. Thank you, Pak Aspinall, for your question. Yes, we think that the current situation is actually open up the opportunity for the popular movement try to inline with the populist element within the administration that can push forward for further reform. Indeed, there is obstacles that faced by these elements. For example, as we know that in the health system, we have not only fragmented but also dispersed health facilities, and this make difficult, for example, friends from the NGOs or from media or academia to try to make a substantial reform, especially in the remote area or in the rural area. But in general, in urban area, we have seen that many populist elements, in this case politicians, are willing to conduct a further reform. As we can see the trajectory in the health insurance scheme, that over time it's grows and become enhanced in terms of the coverage and in terms of the services delivered by the government. But then in the other area or other topics such as tobacco control, where there is no strong public pressure, strong popular or organized popular demand, then we can see there is no much reform taking place in the tobacco control area.
Great, thank you. Oh, did you want to comment, Andrew?
Look, just very briefly to say that, look, I mean, one of the things that sort of, struck me about the cases that we've looked at is just how exceptional the labour mobilisation was in relation to the BPJS law. And I think one of the, to get at your question about the structural obstacles here, I mean, one is, probably the key one to my mind is, and this relates, in particular to the role of what we've called popular forces, is that, there is in a way no natural mass constituency that's got the organisational ability to actually mobilise in relation to health issues. It's not like sick people can go and demonstrate in tens of thousands outside Parliament precisely because they're sick. There are some very, very specific circumstances that led to that labour mobilisation in relation to the BPJS law, and I would think that they're very, very hard to recreate.
Yeah, thank you. Both good answers. Now we have a question from our live YouTube screening. Hi to everybody who's watching via YouTube. The question is from Isabella Apriana, and she has said, during the wave in July and August, there were many stories of frontline health workers who died from COVID while pregnant. Do we have any data on this? And how do we prevent this tragedy from happening again? Tiara, maybe you want to take that one?
Sorry, Sharon, I didn't catch the last bit. Do you mind repeating that?
Just about pregnancy and women dying from COVID while they were pregnant. Are there any data on that?
I think the only data that we have from the OBGYN Association back in, I think, June 2021, where they say around 500 pregnant women have died with COVID-19, not from COVID-19. And also, I think 45% out of those were actually asymptomatic. And unfortunately, our vital registration data is not really good. So we don't really know whether these women, really died from COVID, and how many more are there outside of the 500. Yep.
Okay, thanks, Tiara. Our next question comes from Diana Contreras Suarez, and she notes that it's an excellent presentation. She would like to know if you have any information on how access to healthcare has been changing as the National Health Insurance Scheme has been introduced. She's interested in regional differences and age group differences, and she's been looking at general trends and seen that children are the segment of the population where coverage is the lowest. Do you know why this is?
There are several papers that I've known, and I think one of the more recent one is by Health Policy Plus and also Erlangga, and they did show among the poor population there have been some increase, but also it should be noted that their coverage rate or the use before JKN was very much pretty low. So the increase might be due to just a financial barrier in terms of, and not so much of, an actual access to quality of care. But it's also interesting. I did not know that the trends or the coverage rate is lowest for children, and that would be an interesting one to look at as well. Thank you for the question, though.
Thanks, Tiara. The next one's for Andrew and Lucky. could you please comment further on various avenues for Indonesia to push the right to a health paradigm or health access in the health system to strengthen initiatives in Indonesia? And can the pandemic accelerate such movements? So I guess, can the pandemic help spread healthcare in Indonesia?
Lucy, would you like to again have first go?
Okay. What we've seen in the current situation is that the government really aware that the health facilities, especially at the puskesmas, should be strengthened. And if we can see from the current Minister of Health statement that he is willing to accelerate or improve the puskesmas as the he called it ujung tombak for pelayanan. So I think the momentum is there because we see in Indonesia now suffer not only from this emerging infectious disease, but also based on the Bappenas assessment, for example, in 2018, the trend of the sickness in Indonesia also shift towards more kind of sick or disease affected because of the health style. So and this can become an avenue for Indonesian government to reform the way that they approach and handle the health policy. For example, more and more demand for promotive and preventive measures in order to reduce the number of patients or the number of disease circulated in the society. So I think the pandemic opened up the eyes of many policymakers, and they have the political will. But the thing is, some burden still have to deal with.
Sharon, can I just add a little bit there? Look, in terms of the logic of the argument that we put forward, I guess there are three main avenues, if that's the right word. I mean, one is sort of a broad structural change, a broad realignment of in terms of power relations between the various sets of actors that we identified in the presentation. The Asian financial crisis and the fall of the new order was a moment where that happened. The question here is whether COVID-19 is going to, is a crisis that is going to have a similar level of impact. I mean, at the moment, as I said in the presentation, it's by no means clear that is the case. The predatory forces remain very much in control. A second question is whether there is, for one reason or another, perhaps because COVID-19 just sparks the broad sort of concern that Luki has referred to, whether there is increased popular mobilisation, perhaps involving trade unions, perhaps involving other groups in relation to health issues. I mean, at the moment, we're not seeing that happening, but it could materialise down the track. The third thing is really, how do Indonesia's politicians at the national and local level respond to COVID-19, and in particular in relation to health security issues? I mean, we make a brief reference in the sort of written up version of the paper to the fact that the COVID period has seen a bit of jockeying between different elements within the state to sort of champion national production of alat kesehatan and new vaccines and so on. And this could be signs of that sort of populist dynamic that we talk about in the paper at work, and it could potentially lead to improvements in the nature of Indonesia's health security policies to the extent that it serves to build up greater sovereign capacity to deal with disease outbreaks. But of course, things can cut the other way as well. I mean, one of the things that's going on in relation to vaccines, of course, is there's a particular group within the state who are actively promoting what appears to be a bogus vaccine. So populism can kind of cut both ways, depending on the issue at stake and the moment in time, I think.
Okay, thank you. There's a few questions. We won't get to all of them, but perhaps the presenters could answer those in the chat box. And maybe we'll just end with this last question from Charlie that has asked, what can and what should the Australian government be doing through aid and otherwise to support Indonesia's health outcomes and the right to health? What are efforts from donor countries best spent on? So maybe we'll take a comment from each of our presenters on that, just thinking about how best Australia can assist. Maybe Tiara, you can go first.
Oh, I was going to ask Pak Yodi if you would like to take on this one. I think the donor has been pouring in quite a lot in Indonesia, yeah? But it's more responsive. I mean, responding to the pandemic instead of a health system kind of perspective. So addressing the underlying governance issue and stuff might take a longer term or midterm one. But I think that's where we should be gearing about. And it's often not money issue in Indonesia, in my opinion. But it's also a money issue always, but more of a systems issue. So I think donor agencies, technical capacity improvement would be one way to go for it.
Great, thank you, Tiara. And Andrew, any insights into how Australia can be supporting Indonesia?
Look, I may regret providing this answer, but one thing that Australia can do to help promote the right to health in Indonesia is provide consistent support over time to the health sector, rather than investing a lot one moment in time, change a government, the investment gets pulled out, and then when there's a crisis, as there is at the moment, health again becomes a kind of favourite topic. The same could be said for education, by the way, a crucially important issue in Indonesia. So I think the crucial message for the Australian government here is really, make social policy initiatives a priority in the aid program and maintain consistent funding for them.
Yeah, great comment. And Lucky, any thoughts on what Australia can best do to support our near neighbour?
I think Andrew has described rightly on the steps that the Australian government might follow through.
Lovely. All right, well, Tiara, Lucky and Andrew, thank you so much for a really stimulating and thought-provoking panel. And thank you to all of our guests here on Zoom and also watching through YouTube. So I hope everybody takes care at what is an enduring, challenging time, and hopefully one day we'll be able to all meet in person at somewhere. So thank you all. Terima kasih.
Thank you. Terima kasih.
Thank you.